Whenever you're ready.
Okay, all right. Well, thank you, Sarah, very much. Welcome, everyone, to our November Cost Growth Target Implementation Committee meeting. Lovely to see everyone. I can't see everyone yet, but I hope you are all well and healthy and staying well. And we're wishing you a wonderful holiday season and some time off for a long weekend. We have a very busy agenda today, and it's this might be one of our toughest topics to get through. So there's a lot to be said about that, and we'll get to it in a minute. We also have a couple of representatives, state reps, who are with us, and we'll be introducing them in just a minute. But Sarah, do we want to do a roll call and make sure everybody is here who said they would be here?
We can do that.
Okay.
Would you like me to run through the list?
Please, if you would.
All right, we've got Jack, Kevin.
Yes.
Patrick, yes, I see you. Catherine.
Here.
Bill Ely.
Here.
Felisa.
Yep.
Ruby.
Here.
John.
Here.
Mark. William Olson.
Here.
Goose, get off of it. Come here.
Jordan.
Here.
Ken.
I'm here.
Andrew.
Hi, good afternoon.
Jessica.
Here.
And Jen is not on yet, right?
No, I am.
You are? Okay, great. All right, then we have everyone except Craig, Angela, Shannon, who we know can't attend, and Mark has not joined us yet.
Okay, very good. Well, thank you all for being here. Can I do this? Can we get I don't think we need a motion, but has everybody had a chance to review the October minutes, and are there any and the decisions that we made in October, and are there any concerns, any questions about that before we move on to our November agenda? I'm not seeing anything or hearing anything. So Sarah, I think we can assume that we are good to go. Thank you for that. Now, before we review our agenda, we do have Representative Salinas and Representative Noss with us today, both of whom are active in healthcare policy. We are thrilled to have you both, and we hope you can join us for as long as you would like. I think one or both of you might have a comment you wanted to share before we get started. So maybe I'll turn it over to Representative Salinas first. And if you have something you would like to share with us, please do.
I'll let Rep. Noss go first.
Okay,
given that
all right. Thank you, Chair.
Sure.
Okay, excuse me.
All right, well, I think
Noss.
she's deferring to me a little bit because Senator Beyer and I were the ones that sort of championed this bill. So thank you, Chair Salinas. You know, I had a chance to review the slide deck about an hour before your meeting started, and I can tell that you're at the really hard part. And I'm actually very excited. I know that this is the tough part of the conversation, and Jack, you kind of alluded to that as you were kicking it off. And I don't have to tell any of you that the cost of healthcare across our country and our state is still too high for most working families. And so trying to have a way where the system can control its cost and sort of right itself so that we start to have a more reasonable cost structure is critical. And, you know, Andrew and I were just sort of kibitzing about what we might say and not sort of step on each other with similar remarks before we got on this. And, you know, I would just say behind all of your backs, maybe not in the public, though I suspect the Lund Report is watching what you're doing. But all of us in the healthcare policy space, the governor's office, Chair Salinas and I, and others, we're watching very actively what this committee is doing and what you're coming up with, because we're planning on being able to utilize it to help us get a handle on costs. And not just, you know, in the commercial space where many of you are active, but in the CCO space, in the PEB and OEB space, all these other places where the legislature has to figure out how to pay for all this stuff. And so the work that you're doing is critical. You know, we're not a rich state. so anything that we can do to kind of control the costs for the families in this state, especially during this pandemic, and as we try to come out of whatever recession we're still going to be lingering with, is vital. And so I can stick on till about 1:30ish, and then I got something else I got to do today. But that's all I really wanted to say, is that I'm looking forward to trying to champion your work and arm wrestling with my colleagues to pass something.
All right. Well, thank you, Representative Nuss. We appreciate that very much, and we're honored to be doing this work on behalf of our citizens. And thank you for all you do for our state. Representative Salinas, would you like to make a comment or two?
Yeah, just briefly, thank you. Thank you for inviting me here. So I chair the House Healthcare Committee, and it will we will see if that gavel holds into next session or not, but I hope it does. But I have been following the work of SB 889 even before I was a legislator, and Representative Noce and Beyer were working on this bill, and I was very excited about it. And it's been something I have been talking about over the last year, as well as like just following the work of the committee. But I think it's and I say this everywhere I go, in front of almost every public meeting I go to, I think it is some of the most important work that we are doing right now. And unless we get something that really holds payers and providers accountable, I think the work following it is not going to matter very much, the policy work that we do after. I mean, getting a real handle on cost control and really getting a commitment from everybody is the most important piece in my mind. And so making sure that we have that accountability is crucial. And I'm hearing it from people in my district. I'm hearing it from individuals. I'm definitely, like Representative Noce said, hearing it from small businesses right now during the pandemic, but I'm hearing from large businesses as well, that healthcare and healthcare costs and the continued growing costs are really insurmountable. And we don't see this, it's not a sustainable trajectory that we're on. So I have really been looking to this committee to make commitments, to hold each other accountable. And I really look forward to see what this committee comes up with, because if it doesn't come up with something, I would hate for us to have to cobble something together and try to pass something. I would prefer that you all make a recommendation that you feel is fair, and like I said, something that we could do that's sustainable, and something that we can do, as Representative Noce alluded to, across all payers, public and private. So that's all I have to say. Thank you so much for doing the work. It's been really good work, and I've really enjoyed seeing I will enjoy seeing what you come up with.
I agree with my chair.
Thank you. Yes, thank you very much, Representative Salinas, and we hope you stay chair of this group as well. Does anybody have a question for either of our state representatives? Anybody on the committee want to ask a question or have a comment just before we move on? No, not seeing anyone. Okay, well, you're both welcome to stay as long as you can, and thank you for your support.
Stay on to 1:30.
Okay, very good. All right, let's just take a quick look at the agenda, everyone, and make a quick review. We are, as we have been saying, this is one of the more challenging parts of our work, is to come up with an accountability a method that we feel good about. So we're going to discuss that in great detail in the first half of the meeting. Our folks from the Bailick Group are going to present some information. We have staff that are going to present some information, and we expect to have a very robust conversation about this. We will take a break at 3 o'clock, 15-minute break, because we'll need one. This is a 4-hour meeting, if you recall. And then we will come back for public comment. And after that, we will get into the accountability part 2, where we hope to come up with some, fairly firm recommendations about how we see accountability unfolding in this work over the next several years. We'll then turn to governance and how we are going to govern this group and this work. And that will be about a 45-minute conversation. And then we'll talk about next steps and hopefully have a few thoughts about our December meeting, which is scheduled to be our last meeting, unless we don't get as far as I'm hoping we'll get today. So that is the agenda. Now, before we get into this accountability work, and I know Jeremy might want to make a comment or two, I just want to make sure that we all understand that this is not easy. We don't have a template that we can turn to. Different states that have done this work do it a little bit differently. And I know that there are strong opinions out there about how to make this work accountable. All I would ask is that people speak their mind and be frank and be honest and be candid, but also be helpful. So if you don't agree with some of the proposals that we have asked staff to kind of start with, then let's discuss that, but recommend to us another way or a better way, because we do want to leave this meeting with some specificity around accountability. And we are committed to hearing from everyone, and I look forward to it. And just again, we just want to make sure that everybody appreciates just how important this work is. And I want to recognize all of our committee members right now that are on the front line of the pandemic, and being senior leaders in the healthcare industry right now is really tough. And we acknowledge that. And I just want to say thank you from the bottom of my heart and others for your leadership and your commitment, because between the pandemic and job losses and the fires that we've had and on, this is a tough, tough time. And we want to acknowledge that. But that said, we're doing this work because many of our citizens in our state are going broke because of the high cost of healthcare. And we have to acknowledge it, and we have to do better. And this work is about making us be accountable for a better model going into the future. So with that, I'm going to see if Jeremy, do you have any comments before we turn it over to Michael and company and get us started?
Yeah, thanks, Jack. Just a couple of things. You know, this is in some ways I feel like this conversation today has been several years coming. And as we said, you know, knew it would be a difficult conversation with probably a variety of opinions, and I'm sure that will be the case today. You know, I think I've been just so impressed with this group because, you know, we've had great attendance. Folks have really leaned in, have really stayed focused, you know, are talking about this in terms of how it fits together with the rest of the transformation in the state and where we're headed. And, you know, I think we want to make sure we don't lose sight of that, because at the end of the day, you know, this isn't going to solve all problems, but I hope it provides the platform for more policy conversations around where do we keep going as a state to expand coverage, to make sure we've got a high quality, you know, system that's focused on equity, and that it's an affordable healthcare system. You know, this whole program is designed around the idea of there not being, you know, not focusing on just one problem in the system, and that there be some flexibility for folks to some degree, kind of, for lack of a better phrase, kind of choose your own adventure to figure out how we get to the cost growth target. And I think we're all hopeful. I'm hopeful that transparency and folks really, you know, making a commitment to this gets us there. And, you know, we've seen that in Massachusetts. We've seen that in public programs that, you know, sort of having folks make a commitment and transparency get you a long way. I think the piece we're struggling with is also making sure that folks, you know, take this charge of needing to contain costs seriously, and that you know, having some tools that ensure that that hopefully we don't ever have to use, but that do provide that backstop around accountability, whatever that looks like. And you know, I've heard from several folks over the last year around sort of a fairness issue of, you know, what happens if some folks in some parts of the system are really leaning in and trying to contain costs, and other parts aren't. So, you know, we don't know what the right answer is here. We've got really one other state to look to that has done accountability, Massachusetts. You know, I think reflecting back on the original 419 task force a couple of years ago, which several of you were members on, I remember the conversation. I remember a couple of conversations where folks wanted to deviate from Massachusetts, one being us putting in an even larger focus on transparency, and that the state have a sort of suite of tools that it could use, and not just one tool, so that there wasn't just sort of one giant hammer, but that there would be, you know, sort of several incremental steps. With that said, you know, we don't really know what those incremental steps are, so we're kind of making this up as we go. You know, I think Jack sorry to put you in the spot, Jack, but I think you were pretty clear. You really want us to put something out there for folks to respond to. It might be wrong at first, but let's sort of get something out there and let folks respond to it. So, we're not married to where this ends. Really hope a lot of folks have provided great feedback to me over the last day. I really appreciate everybody being really candid with me around where you're at. I think we want to make sure there's a lot of time for robust dialogue, and we will spend today getting around to everybody's comments, and we hope that starts to point us in the direction of refining things to get to consensus. But I think one, I want to recognize the amount of pressure everybody's on and the amount of COVID, and two, want to also recognize that we're trying to invent something here that nobody else has invented. So appreciate a bit of grace as we're trying to work through this. So with that, I'll turn it back over to you, Jack. Thanks.
Yeah, Jeremy, thank you very much. And before the representative Noser and Salinas may have to leave us, I just want to acknowledge the phenomenal leadership that we've gotten from the staff at OHA. Jeremy and Sarah and Tara and the entire team. And Pat, thank you for making them available, but we could not have gotten as far as we have without them, without our consultants who you'll meet in a minute. They have just done a magnificent job of making this work come to life. So thank you all very, very much for that. With that, Kevin is my fantastic co-chair. Kevin, do you have anything you want to add before we get started here, please?
Hey, Jack, I think you set it up really well. This has been a discussion that's been in the making for the last couple of years. I think that the will of the group and the intent of the group is to still move forward in some capacity that makes sense, only because we have invested so much time and effort as a work group to try to get there. I acknowledge as well that we're going to have to allow the participants to all speak candidly and to speak their truth to get to the other side. I believe in our state, and I believe in the people on this work group, the implementation committee, that we can achieve the task at hand. It might be somewhat different than what is initially presented, but I still feel that we can get there.
Very good. Thank you, Kevin. Okay, so unless there are any other comments, I would propose that we move into the first part of our accountability discussion. And I think Michael and Megan, Sarah, is that right, are going to take this away and present us with some modeling to consider. Okay, so.
Thank you, Jack.
Thank you, Michael. Welcome. Good to see you.
Hi, everybody. Nice to be with you again. Good afternoon. Sarah, can we go to the, Sarah, do you want to say anything to Bob Proctor, or is this just to set us on our course?
This was just a placeholder for opening reflections.
Okay, thanks. All right, then why don't we move to the next slide? In order to start this conversation, we thought it'd be helpful to make sure that we have some vocabulary that's commonly understood. And so we want to distinguish a couple of concepts that have appeared over the course of our work. The first one is the topic of transparency, which sometimes has been described as sort of an overlaying work stream over all the work that we're doing. We've talked about transparency in prior meetings, including plans for public reporting of results. Sarah walked us through the methodology for how that would be done. And we've also talked about plans for holding an annual hearing to share the results of performance against the cost growth target every year. For today's conversation, we're not going to be talking about transparency. I know that some people believe, as do I, that there is in fact some accountability that comes from transparency. But for today's conversation, we're not talking about transparency. We're talking about other potential activities. All right, and those other potential activities we're putting under the umbrella of accountability. So these are potential procedures for a situation where a provider organization or a payer does not come in at or below the cost growth target. Okay, so I'm going to start now with what does SB 889 say for the charge of this body, because I think that establishes the parameters for today's conversation. So it recommends that, or actually it directs that all of you recommend accountability and enforcement processes, and it notes they can be phased in over time. So there are a couple on this slide that I want to distinguish. One is accountability and enforcement related to reporting requirements. And as you may all recall, the way that we're going to assess performance against the cost growth target at the state, insurance market, insurer, and provider level is by having payers submit information. So we're not talking today about accountability and enforcement for submission of data by payers, okay? We'll talk about that at another time. We're really talking about accountability and enforcement for performance relative to the cost growth target, okay? And really about insurer and provider. Can we go back? The 889 says that there should be procedures for imposing a performance improvement action plan or other escalating enforcement actions. So 889 is clear about utilizing a performance improvement action plan. It is not specific in terms of what escalating enforcement actions are. Those are for you as a body to deliberate on. And today, to help support our conversation, we're going to give you a straw model of what they might be. But I just want to clarify, 889 is clear on the improvement action plan. It's not specific on anything else. Okay, thanks. 889 also says that when looking at enforcement actions relative to the cost growth target, that the measures may include, but not be limited to, programs administered by OHA and DCBS. So again, may include, but not limited to, as we consider options. And so medical assistance, PEB, OEB, the exchange, those are all benefit programs of different types offered through the state. And then finally, review of health insurance premiums by DCBS, which is obviously a little bit different than the other programs, which are benefit programs and involve purchasing activity on the part of the state. So this is the 889 charge as much as it is defined, and I just think it's helpful knowing what we've been directed to consider. In addition, the governor directed the committee now a year ago, next slide please, to look at robust enforcement and accountability for holding carriers and providers accountable for meeting the target. So I think this amplifies what's in 889. I don't think it provides anything different than what's in 889, but it certainly amplifies that message. So I want to pause now and just ask if there are any questions about the charge that we've been given, because what I want to do next is recap a little bit of last meeting's discussion and then begin to share a straw model and invite you to react to it. So any questions about the charge?
Michael, this is Ken, and I wouldn't say it's a question. I struggle a little bit to have accountability and enforcement be sort of on this parallel. I mean, I see accountability as having people own the results, and the enforcement's what happens after that. And I think that's an important distinction as we think about what the plan needs to look like.
No, that's a good point. Yeah, you know, that the legislation and the governor's letter do not distinguish them. They sort of treat them as if they were synonymous, but you're right, Ken, there is a different meaning between accountability and enforcement. Jack, did you want to say something? You're muted, Jack.
Sorry, Michael, I was on mute. Can you go back one slide? I just want to make sure that I know it's part of it, but Medicare is not in this list, and we just want to remind everyone that Medicare and Medicare Advantage and all the lives associated with that in our state are part of the equation too, right?
Right. Yeah, right. But the state doesn't really have any compliance leverage.
They don't. That's right. Okay, just to clarify. Thank you.
Yeah,
Minor
thank you.
point.
Anybody else? Okay, so I want to recap a little bit on the next slide, our prior discussion. One more slide, please. Thanks. About how performance will be assessed. So you might recall we talked about this during our last meeting a little bit. Again, payer data will be collected by OHA. It will come in from carriers and from CCOs. It will also come from CMS for Medicare fee-for-service, and there'll be some Medicaid fee-for-service as well. So these payer submissions are all going to come in, and initially they'll be validated. When I say validated, I just want to note that submissions are of aggregate data. They're not of individual claims. So the validation is as much validation as you can do with aggregate spending data. It's to look for whether it's complete and whether there are any figures that don't make sense. For example, Megan recently was doing some data validation for another state, and there was one insurer that submitted data that indicated that their commercial spending per capita had grown 20% in 1 year. That was suspicious, and so that was part of the validation process. So she went back to the carrier and said, "Are you sure this is right?" And no surprise, it wasn't right. So it made a correction. So that's what we mean by validating the submissions. Then the next step, as Sarah explained during the last meeting, is applying statistical testing to ensure confidence in the results. And when I say confidence, I mean certainty as to whether the performance of the state, market, insurer by line of business, provider organization by line of business exceeded or met or fell below the target value. So that's what the statistical testing is intended to do, so that there's a high level of confidence that if there's an assessment that the target wasn't met, that there's some strong analytics to stand behind it. Okay, so that's what we've talked about in the past. Everything that I'm about to talk about is a straw model for what might happen next in terms of steps. So let's imagine that there is an organization, payer or provider, for which the statistical significance testing indicates that the organization was above the cost growth target for a given year. So the suggestion here is that there would be a discussion with the organization about its cost growth being over target and some exploration in terms of why that might have happened. Now, OHA will have limited data to explain it. There will be information that will probably distinguish or break down spending growth by large service categories, but that certainly won't tell the whole story. So this would be an exploratory conversation, and it would attempt to distinguish whether the spending being over the target or spending growth being over the target was for reasons that could be justified or not. So what does justified mean? We're going to spend probably a lot of time on this topic today. So we don't know the universe of reasons why exceeding the target might be justified, but we certainly can think of examples. And I think it's possible to develop some general rules, but probably not certain all-inclusive rules. So I'm going to give you a couple of examples. We've shared in the past that Massachusetts in its second or third year shot through its cost growth target. Well, that was the year that medical treatment became available for hepatitis C. And as you're all aware, the drug Sovaldi was extremely expensive, and there were a lot of people with hepatitis C for whom a one-time treatment would cure them of the condition. And so spending that 1 year shot up for a treatment of hepatitis C. So that's the example of say, a miracle cure that appears super expensive and lots of people need to get treated at once. Another example we're living through right now, a pandemic, okay? I would imagine that 5 years ago, if we were developing criteria, we probably wouldn't have put pandemic on our list. But certainly, healthcare spending nationally was depressed, especially in the earlier months of 2020. And if spending does not have such a dip in 2021, say because of the distribution of a vaccine, then we would expect that 2021 spending will grow significantly over 2020 because 2021 will not have had that trough that occurred in the March, April into May period. So those are two examples of what might be justified reasons for exceeding the cost growth target, and reasons that perhaps could not have been foreseen in advance. So this proposed step is that if an organization is above the cost growth target, there's a conversation that takes place where the provider or payer organization would be invited to explain what they think happened, and specifically what contributed to their exceeding the cost growth target.
Hey, Michael, before you move on, I want to hit on this point real quick. I see this as I don't think this conversation is just about can you explain it? I mean, I think what I've heard from Massachusetts is the way this has generally worked is, you know, the state brings some of its data and information and says, here's what we think is going on. Can you explain what's going on? Is that right? I mean, I think this is, you know, a part about why we're focused on the target and it's justified, but I also think it's about, you know, an important dialogue on us as a state trying to understand what's going on. And I think also being able to share some information around maybe how the, you know, individual organizations' performance varies from other trends that we're seeing in the market. And, you know, I heard in Massachusetts as an example that in these one-on-one conversations, they've been able to say, we're seeing these parts of your spending that are sort of out of whack for the rest of the market. And that has actually been helpful for the individual organizations to be able to see where some of those opportunities are as well.
Thanks for that, Jeremy. William, you raised your hand?
Yeah, I did. I thought earlier on, and maybe I'm just not remembering it right, but one of the things that to help us understand, I thought the data where it would lead us is that we were going to look at 2018 and 19 and look at the information as sort of a dry run.
Mm-hmm. That's right.
So where are we? I mean, because it's really hard for me, you know, without data to kind of understand what some of these, you know, reasonable reasons could be, what's justified, not justified, and how we look at the information. So where are we in being able to get that information as well?
Okay, well, that's in process. Sarah, do you want to talk about the planning process as it stands right now?
Absolutely. So we have been working internally to draft the data submission template and the specifications that the payers will use to submit that data. We anticipate standing up a technical group where we'd like to invite all of the payer organizations that will be submitting data to help us review that, test that, make sure the specifications make sense. I'm hoping that we can get those invites out sometime in December. I don't know if we'll be able to meet in December or if we'll wait until January, but we're getting pretty close to reviewing that submission template. Once we've had an opportunity for everyone to review, then we'll set the timeline for the data submission for that 18-19 baseline data. So early next year.
Okay, thanks.
I just would add, you know, we've talked about 2021 being the first year of the target, and we'll talk about the timeline a little bit here, but we've also, to just jump ahead, I guess, we've said that we're proposing it's not till really the second year of the program. So really in 2022 would be really the first year we'd be looking at accountability, but in any event, 2021 would be the first year we measure ourselves against the target from growth to 20 to 21. The reality is that we won't know that outcome till the second half of 2022. So we're anticipating that 2020 and 2021 are really 2 years when we'll be looking at the sort of baseline data and be able to go through the validation, be able to go through conversations as sort of a dry run of here's what's looking like it's happening before we even get to reviewing that first year of did we meet the target or not.
And Jeremy, realistically, we're already in 2021. If we were going to have any major impacts on 2021 and understanding the data, that should have already been kicked off and going now. It's really hard to know where to focus when you're going through the pandemic. So I worry about when we say we're going to make 2021 your first year to try to understand and hold people accountable. We're at the point right now, and I foresee for at least the next 4 to 5, 6 months, it's survival.
Thanks, William. And I'm not dismissing that. I just assume we're going to have a lot more conversation about this when we get
yeah.
to the presentation.
Let me go a little bit through. I have 3 more slides to get through just what the process will be. So let me go through those, and then we can open up for some more conversation, because I'm worried that we have conversation before we've presented some contextual information to you. Is that okay? You want to object? Okay. All right, next slide, please. So the accountability mechanisms, which we have not, or enforcement mechanisms maybe, which we have not talked about yet, will only be, this is the proposal, apply to provider and payer organizations that have exceeded the benchmark with statistical significance or confidence, which we talked about again last time, and for which there's no reason that can be identified that's assessed as justifiable for exceeding the cost growth target. And that could be for one line of business or for all lines of business. So if we map the process, the next slide has a little bit of a process diagram. So carriers submit data, as I noted. Also, data is going to come in from Medicare and fee-for-service medical assistance. It gets validated and analyzed. After there's reasonable confidence that the data are good, there's statistical confidence testing applied to it. And then if a given organization is above the cost growth target, there's the one-on-one conversation that Jeremy was just talking about, in which the entity that was over brings their reasons. The state might say, we've done some analysis, here's what we're thinking, and there's some back and forth exploration. And following that, there might be some further analysis to identify key factors driving spending growth, because all the reasons may not be completely revealed through that one-on-one conversation. So there might be some iterative conversations until there's a understanding of what happened. And at that point, there would be what we're just calling here nebulously as an accountability determination. We're going to go there next in terms of what that means. But I think this is the assessment of was the spending exceeding the target justified or unjustified, and then what should happen as a result of that. And the what should happen we haven't gotten to yet. After that point, there would be public reporting on performance against the target, and the public hearing that we've talked about before to examine what happened at the state level. Did the state hit the target or not? And maybe some exploration. What are trends that are driving healthcare spending in the state? And then on a go-forward basis, oversight. And who's doing the oversight? Well, certainly there'll be some ongoing oversight by the successor body to this implementation committee and by the Health Policy Board. And to the extent that there are some enforcement actions taken by OHA and or DCBS, then one or both of those agencies. So that's the flow. I have just one more slide, and then we're going to pause and open up again. So the straw model has no fixed criteria for determining what is unjustified growth. That doesn't mean that there are no criteria. It just means that they're not absolute and limited, because, well, for the reasons that I explained before in those two examples. And it's quite possible, if not likely, that an organization that exceeded the cost growth target did so for more than one reason. The factors that would lead to an assessment that exceeding the target was justified could be environmental, market-based, or due to government action, or some combination thereof, but would have to be completely outside of the control of the organization. And then finally, the organization that exceeds the target, while, as Jeremy said, the state's going to bring some information, there's some responsibility on the organization that exceeded it to come forward and make a data-informed case on what were the reasons it exceeded the target that made it justified. And the reasons have to be significant enough to have caused spending to have exceeded the target. So there may be reasons that are driving healthcare costs, but they may not have been large enough to lead to exceeding the target. So there's a little bit of a scope and scale impact assessment when assessing whether the reasons were justified. Okay, so this is the process. We have not talked about, so what would be the accountability options, except we know a performance improvement plan is specified in 889. Before we go on to talking about those options, I'd like to pause again and talk about this process, including the process that we were talking about a little bit before of OHA sitting with the organization and having a back and forth and some data analysis to try to understand what went on. People have reactions to that process. Does it seem reasonable? Are there recommendations you'd like to make for refining this proposal? And if so, please bring them forth right now.
Great comments, everybody. Who would like to, who has a thought on this?
This is Jen. I'll start with a question. There's a couple things that strike me as what is a rational process to assess justified or unjustified. And it feels like there's an element of the triple aim that's certainly missing here, potentially in terms of quality and overall health factors. And so when I think about justification, I also have a question about how will providers and payers, but providers have access to the detailed data to understand it, because if the onus is, as this states, on the organization to justify or explain what has occurred in their market, having a deep understanding of the data is critical. So how will everyone have equal, or how would everyone in this scenario have equal access to that data? And what is a collaborative way to talk about justified? This seems very, or it has a tone of being very unilateral or with judgment, just as an initial reaction.
So Jen, I'd like to both respond, but I'd also like to ask you to propose what you would like to see. Okay, so I think you talked about a couple of things, data and the determination of justified. So I'll talk a little bit about data and share a couple thoughts, but I'd love to come back to you and ask you on what is a multilateral or bilateral approach that would feel more comfortable to you. So on data, which I think that's a great question. I have a couple of thoughts. One is, when the payers submit data to the state, there will be information that in that one-on-one discussion, OHA would share with a provider or payer organization. Now, the payer organization will know its data. The provider organization may or may not. So OHA would be able to take the data that came in from the payers and bring it to the provider organization and say, this is what we got from the payers. They followed our rules. Here's the parameters and what we told them to submit to us. We know the total spending, and we have a breakdown of what it was for major service categories: pharmacy, outpatient professional, primary care, inpatient, for example. So that would lend some insight and certainly transparency that's appropriate. that would be my answer number one. Now, obviously, there's a lot more detail that lies below those categories. I think that there are a few options in terms of how we get insight to those levels. Now, one obviously is the payers providing you with that information either through reports or report tools or claims transfers. Another opportunity, although one that probably would not be as timely, would be our data use strategy that still needs to be developed and the types of analytics that would be appropriate there. So I think the first part of it, the OHA bringing you what the payers provided and showing you, assuming that you're the organization just for this case, that part's pretty clear. The other parts, I think there are some options there.
I guess on the data piece, I do feel like there's going to have to be supreme transparency of sharing and I'm just going to put on a hospital hat right now. That's obviously hospitals are going to be in a a TME accountable organization. We only receive from payers claims that are processed for our organization. We don't have line of sight for the costs associated with all the other costs those members incur that are not billed by us. So having timely access to that is going to be just paramount for us to understand what is going on. And so I feel like there has to be some really deep work and understanding on what the data is, how we can access it, and then what tools are available, because not every organization may have the ability, depending on if it's a rural healthcare provider, a small hospital, to understand and analyze their data. So I just have real concerns that we'll be asked to understand and know what something occurred without being on equal footing or even having the skills to do so.
Yeah, so to me, this calls out for an opportunity for this body to take some action to try to encourage the provision of payer data to organizations like yours so that you have a picture of total spending delivered outside of your system, in addition to that delivered inside, to help you succeed. And I would say the sort of slow ramp up of this program over a couple of years certainly provides some time for that. But there's no question in my mind that provider organizations getting complete data from payers to help them understand total medical expense will be of great benefit, both for your contracts that you've got that are total cost of care, but also relative to the cost of target. So in my invisible whiteboard right here next to my desk, I'm noting that as something that might be good for this committee to come back to as a potential area of activity to help ensure cost growth targets success.
Yeah, and I would just add, and I know there's others that want to speak. I don't think it's just good. It is an absolute must-have. We can't succeed at doing this if we are flying blind. And if the expectation is that we're not flying blind, then we need the full support of the state to allow us to see that. And I can think of 1,000 reasons that there's barriers, rate setting, and all of in the sense of sharing rates, because once you see claims, you understand cost. So I just want to emphasize that's a must-have. We can't be asked, or I don't know how my organization would be asked to do this if I don't have access
right. Well,
to
hopefully,
behavior.
If the baseline analysis is completed in 2021, which I'm guessing, Sarah, is your plan, you'll see some data in the not too distant future from the first baseline period. Jen, I want to come back to you about your concern about how justified is determined. Do you have a proposal of how it should be done in a way that you said felt unilateral? Is there an alternative way that you think would have integrity that you would prefer?
So one, I feel like we haven't had a lot of time to digest this, right? This
Sure.
information and white paper came out. So I don't feel it is a fair expectation that we're showing up with a written
That's fine. That's fine.
response. But my sense is that Justified felt like, when I read the document, focused solely in the hands of OHA, perhaps, as the determiner of justified or not. And it didn't speak to quality or value or the length of time that an investment in change in care delivery may take. So there's a time element as well that feels absent. So it just felt very unilateral, which if we're all trying to change this, it has to be collaborative on the understanding of the costs to make sure that they make sense.
Okay. So I want to say both to you, but to everybody on the committee, that recognizing this is our first time talking about this, we will have time on the meeting agenda for the next meeting to talk about this further. And if in between meetings thoughts come to you that you want to share that just didn't come to you during our meeting today, then please share them with Sarah so they can be incorporated into our discussion and any revisions we do to the modeling.
Yeah, absolutely right.
Jack, I noticed we have a couple of hands up.
Yeah, please. I can't see them, so
okay.
You go
So,
ahead.
so Catherine first.
Catherine both have their hands up right now.
Okay. Catherine, why don't you go first, and then I forgot who else you said, but that person will be second.
Lisa.
Okay. Thank you for presenting this. I wanted to echo what Jen said, but also suggest for this first step, you know, as we think about stepwising through the process, this is the first, but not the only time that OHA is the sole determiner of whatever decision needs to be made. And so at this stage, I would agree with Jen, having gotten this Thursday and not a lot of time to digest, I don't have a solid or an appropriate response as to what an alternative would be to justified or not. And I would want to go through the whole process and try to think about due process in some ways, to think through what would be an alternative. But as we step through the other parts of this process, pull them, those decision points, and look at them in total to think through what an alternative may be.
That's totally reasonable.
Yeah.
Thanks, Catherine.
Who else is speaking? I'm sorry.
I think I got a little bit lost. Sorry, Jen, in the data conversation that Jen was outlining. Can you go back a slide, Sarah? I think to the sort of chart. If you can't, that's fine, or I don't actually know who's running the slideshow. Okay, so I just wanted to make sure that I'm correct on this. So before you ever get to the data accountability determination, or the accountability determination where I think the performance improvement plan comes, you'll have all of these steps on making sure the data is accurate, right? So this is a step-by-step. It is a process timeline, not a unilateral. Okay. So I think that that's really important, because I hear Jen, I want to hear Jen on the data and making sure that you're getting the data and making sure it's coming back to you, because I do think that we haven't really closed the loop on that between carriers and providers, right?
So, yeah, so that bottom box in the middle column, that's where OHA would bring the data that was submitted by the payers to the payer or provider organization. Again, it's more likely to be provider, because the payers are submitting the data. They know what they're submitting. So it's more likely to be, it's going to be brought to a provider organization. And OHA would show the analysis that it performed, both with the submitted data for the cost growth target, as well as any complementary analysis that OHA happened to have performed.
Okay. So so then like the carrier submit, we do the validation, the initial results, then there's a collaborative discussion to make sure the data is correct. Then there's the then the second piece here, to Jen's point, understanding key factors driving costs, I assume is also another collaborative conversation to bring key factors together here. So you may have factors as a provider or a carrier that you'd like included. There may be market or global factors, as you pointed out, Michael. So I think here, and maybe it's the wording in this. Sorry, I'm like pointing at my screen like that's helpful for anybody. I think the understanding key factors component is just another piece where it's not just OHA's understanding those key factors, but it's another discussion point. So
yeah,
maybe
there's a lot of iterating and a lot of conversation.
Okay.
All along between OHA and the carriers and OHA and the providers, and sometimes it could even be OHA, the carrier, and the provider.
So I think so I think maybe to Jen's point there, that should be just a little bit more clarified, that is also a collaborative conversation in determining those factors, because then I think that then brings you to the accountability determination about justified or not justified. Because I think at this point, you're really, when you get to this accountability determination, my hope, and I think most of the people on this call's hope, is you have knocked off 99% of the carriers and providers at this point. And you're really talking about people who then go into, to Ken's point earlier, a performance, an accountability conversation. And that's for self-accountability, right? Where you're really digging into the data, back to Jen's point, and looking at, okay, what do we need to do internally to get to an agreement on, like, how are we going to change, right? That's the next step in the process. That's also a collaborative process, right?
Mm-hmm.
So if you're a Jen or sorry, Jen, I keep saying you because if you're a provider, I'll stop saying, if you're a provider or payer, then you have another collaboration point where you're going to jointly decide on your project improvement plan, or PIP. I can't remember if it's performance improvement plan. So that's another joint decision making, right? Is that the PIP? That's also joint?
So the PIP is developed, yeah, OHA with the organization.
Okay, so maybe a little bit more clarity about that, how that's jointly done to address that issue. And then to Ken's point, then you might get into the enforcement if you've decided, I don't like this PIP, or we can't meet this PIP. But just because you have a performance improvement plan, you can come back around for your second time to determine if you meet that or not, right? Because it's a 5-year period from start to finish of this whole process. So for 5 years, you've gone through this process of continuously not meeting your target, right? From the earlier.
Well, that'd be every year, but it's multiple years during the 5 years.
Most of the years during a 5-year process. Okay. I feel like it was really confusing for me because I thought it sounded a little bit like this was like a boom, 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 you're done and being held accountable. And it seems like we just need a little bit more clarification in the language that you're using, how collaborative and what the timeline is on this process, and maybe combining the presentation from last time, merging it with this could help clarify some of those things. Thank you.
And to show the processing that's going on.
Yeah,
right. So
thank you.
There are 3 hands. I'm sorry, Jen, there are 3 others who raised their hand. So, but I'll add you. So Bill, Pat, William, and then back to you, Jen.
Yeah, I've got a point of clarification back, part process, part this conversation around the justification. But back, if you will, to the statistical confidence testing. And I think what I inferred from the prior meeting just might make this a point of clarification. But year over year, you'll have some measure, presumably a risk-adjusted cost per member, and we're comparing that year over year and seeing whether that exceeds the benchmark. to the degree that the data validation is done, you know, that seems like a calculation and not something you put a confidence interval around. So I think what's going on here, and from the prior meeting, as I mentioned, is what we're really saying here is we've got this observed result and we're doing some statistical testing that says it's not likely to be a random statistical variation event. And so, you know, moving ahead to the justification, I think what sort of is implicit in that, if a provider or a plan finds themselves running ahead of the benchmark, that in essence the phenomena of it just being, you know, an adverse random effect have already been taken into account by the statistical testing. Is that what's meant by this, or is there some other thing going on with the statistical testing that implies something about the cause, if you will, of this, you know, this calculation that shows you're higher or lower than the benchmark?
You know, I think you properly characterized it. By doing the statistical testing first, we're trying to make sure that we've got certainty about the findings and that it's even appropriate to have a conversation about the reason that an organization's above, because we know that they really are above.
Thank you.
Okay, Pat?
Yeah, some of the discussions led me to wonder if something I'm assuming I should ask just to be sure I'm right. And I was thinking particularly about Catherine's comment about OHA being the sole determiner. I'm assuming that somewhere in here, and it's not clear to me whether it's in the accountability determination or the public report or somewhere else, but at some point we make a finding that becomes in effect an administrative decision, and that there would actually be the opportunity for there to be some sort of an appeal around that. Have I got that right, or am I making things up?
Yeah, I think you're right. We have not identified that here in this process map, but presumably if OHA, for example, was to take action, there would have to be some appeal process. I would note that if the iterative conversations that Felisa was talking about have been as robust and complete and earnest as they've been, then that should address anything that someone might appeal, but probably technically you still have to have a process.
So it becomes similar to the commercial insurance rate setting process in the individual market, for example.
So let me just ask, Jeremy and Sarah, do you guys?
Yeah, I agree. I mean, I think the, you know, I guess I don't envision the one-on-one conversation saying, you know, hey, you're above the target, you know. I guess I would imagine those being more collaborative in nature. And, you know, we probably haven't described that, but I would imagine it being more of a fact finding. We're trying to understand why. We're trying to understand. You understand why, and that would be a back and forth of sharing information and trying to understand it. And that would be the sort of first spot. And then I definitely agree that I mean, constitutionally, I think there has to be an appeals process, but you know, I wouldn't imagine this being OHA makes a finding and nobody understands why, and then they're appealing it. It would be after a process of, you know, back and forth and collaborative conversation, information sharing through the one-on-one conversations.
Yeah, and I'll just go ahead.
I would say again, broadly similarly in the commercial insurance rate setting process, there is a hypothetical appeal process, but it's rarely used because there is this back and forth actuary to actuary that work out and get to a common understanding of what the facts mean.
Right. Hopefully that would happen here. And I'll also observe, so all of you who've been participating in this process now for, I think, over a year, all of you and OHA and DCBS all have a shared interest that the cost growth target is achieved. And so the collective work of this body and its successor will really be to figure out what are all the ways that collaborative action can lead to success at the state level and at the individual entity level. William.
Yeah, my comment was more, and again, I don't have a definition either for what's justified, not justified, but maybe it's language. Because I like the way Jeremy started out saying it's an open dialogue, and that should be the key to understanding and really trying to figure out how to control costs. But when I read on the slide, when it says the onus will be on the organization exceeding the target to provide evidence, that doesn't sound collaborative in there. And so if we could really kind of work on what does that collaboration look like, so we're not really penalizing each other, because I think we all have the same goal in mind. I would love to hit the 3.4 and, you know, figure out collaboratively how to do that, instead of feeling, if I feel I'm under the gun and the onus is totally on me to justify, I tell you what, I'll come up with everything under the sun, and maybe it won't be as collaborative. So if somehow we can figure out how to be more collaborative in this first phase, you know, I think that would go a long way.
That's a great point. Yeah, and as I'm reflecting, I think our description of the process hasn't been sufficiently expansive, and so the language, which might be too terse, probably created an impression of something that is less collaborative and process involved than I think the intent. Jen, back to you, and then Ken.
So two comments. One, just on what we were talking about, is I don't see in this where we are learning from those that are meeting the target. It feels very much like we are focused in only on those that aren't. And for us to raise all boats, we need to have this be a collaborative learning environment. So it feels like that deep data analysis and understanding has to also happen.
We will be with you shortly. At Slocum, reevaluating.
For those that are meeting the target, like what is the mix of costs and all of that. So I just feel like that needs to be part of this. The other is, and maybe it's later in the presentation, to really talk about timing. Because as I look at some of the examples in the document, take for instance, 2022. As a provider, I won't know how I did in 2022 until probably the latter part of the third quarter of 23. And then to have time to analyze and learn from that, I may not be able at all to affect change in my care delivery system until 24, meaning had the same situation or factors persisted in 23, I've now failed 2 years. I'm now trying to make change, and I'm now having enforcement action against me. I feel like the timing is disconnected from how quickly data is going to be available that's useful, and how quickly a massive system can respond to change. So I'd like your perspective on that, Michael.
Yeah, so I think this amplifies the point you made earlier, that it's necessary to have a process for provider organizations to get information outside of this process and on an ongoing basis that gives you insight into what are trends for total medical expense for your population or the patients who are attributed to your system. And your first point, Jen, the sort of learning from those who do well, I'm reminded that a couple of meetings ago, we had a discussion of the Taking Action work stream, and we were sort of brainstorming on what were things that OHA could help support that would result in achieving the cost growth benchmark. And I think you've just identified a second one. So with my whiteboard that's not really here, the second thing I would write down is create an opportunity for cross-organizational learning for provider organizations to see what different people are doing that's leading them to be successful. And what's likely to be cross-market learning as well. So you may well be learning from someone who's somewhere else in the state, not competing with you at all, but doing something that might transfer well for you. So I think that's another potential opportunity or work to help ensure success relative to the cost growth target.
No, I agree. I think that's a great point.
Ken.
Thanks, Michael. My comment's probably very consistent with William and Jen, and oddly, I never wordsmith, but and just be two wordsmith comments in the same meeting. Even the terms justified and unjustified, to me, has some connotation that leans itself towards enforcement versus accountability. I don't want my organization to develop a competency in justification. I want us to drive towards improvement. And there may even be situations where what we want to encourage is, even in some cases like the pandemic, there might be justification. We still want to be developing mitigation strategies, right? We still want to be driving forward. So it's about, I think, creating an environment that really drives towards that continuous improvement and supporting it with having the backstop of enforcement. So I don't know how to mitigate that, but I do think the language ends up being important. And then the last comment I make is, and it's sort of obvious, but we need to be thinking, I mean, we can all say nice things to each other about how we're going to collaborate, but we won't all be the same people around the table in 5 years. So we need to be thinking about, let's make sure we're building the system with the infrastructure that goes beyond us.
Yeah, great point. Megan just shared a comment from Felisa that the word justified is actually in 889, but that doesn't mean we have to use it. And so I think we certainly can consider some alternative language for communication.
Just to clarify, Michael, I actually think it actually states that the committee does have to come up with a determination of justified and unjustified. So it's like, so just to clarify for people, it's not, it wasn't like one of the optional picks on here. I know it's really harsh language, but I think they just pulled it from the bill.
Yeah, right. But going forward, we can use other vocabulary and still meet the 889 charge, I think. Yeah. Okay.
Michael, it's Kevin. I have my hand up.
Sorry, Kevin.
So my question, comment and question, is moving from the first box where we see carriers submit data, and then moving into the data validation and analysis. And also the comment that we've heard a lot over the years of garbage in, garbage out. And my question may be more for Sarah, but we have all been used to the all payers, all claims system since 2009. And then in 2021, we'll be transitioning to HSRI as a brand new vendor, correct? So my question is, will that vendor be ready, willing, and able of collecting all claims from all payers at the very beginning? Do we need to build in some flush time to ensure that they have the processes down correctly?
Kevin, let me jump in, because I think a couple things are getting conflated here. So yes, we are transitioning APAC to a new vendor, that's HSRI. Yes, that is in transition, happening in 2021. The APAC data submission, the data formats for APAC, all of those rules, that all continues. This doesn't change that. What we're talking about when we say carriers submit data is new data submission. There'll be a new template. It's an Excel spreadsheet at this point. It's not as complicated. It's aggregate data, and that would be submitted directly to staff. It won't be going through HSRI initially. I think we're really intrigued by Massachusetts, which has merged its cost growth target and its APAC data submissions into sort of a single process. I think maybe there's a future state where we look to align more, but I think at this point, this is a separate data submission that's specific to 889, and it's coming to staff, not through HSRI.
Okay.
Yeah, and just a refresher. So I know we've talked about this before, but I think it's an important point to keep hitting on. So that whether or not we're meeting the cost growth target, or organizations are meeting the cost growth target, will be a carrier supplied submission to us that's separate from the all payer claims database. In large, we've talked about there's challenges with APAC. We'd have to be doing our own attribution and validation, and we've been missing self-insured and a number of challenges. But we'll be using APAC for the deeper dives of what do we see as trends that are happening in the market. And certainly, as you know, Michael's talked about our data use strategy, I think all the points that others have made, certainly we want to keep evolving the use cases of APAC to be supporting our understanding of what's happening in the market, as well as opportunities. You know, I think our work on the low value care is a good opportunity where we're trying to use APAC to help provide, you know, folks in the system with an idea where there's opportunities, but it's not directly connected to the initial analysis of who's above or below the target.
Okay, so what I've heard through our conversation over I'm not sure how long it's been, is one, the description of the process needs to more fully reflect the collaboration between OHA and provider or payer or both organizations. And not only the collaboration, but sort of the iterative discussions that would go on to try to identify the sources of cost growth and including that future PIP perhaps, how best to address them. I've also heard that we need to reflect the necessity of an appeal, the desirability of using a term other than justified, even though that's what's in 889, but finding something that is a little bit more reflective of a collaborative process. And finally, I want to acknowledge having heard from at least Jen and Catherine the desire to reflect upon information that you did not get far in advance of this meeting, and to come back with additional thoughts when you've had the opportunity both to reflect further, but perhaps also to confer with colleagues. Anything else that was just discussed that's important anyone wants to note?
Yeah, this is
Hi, Ruby.
Hi. I've been listening to the discussion, and what I'm picking up, and I've got the kind of communications background here, I'm not the medical person. When you put up the word accountability does have drop downs for responsibility, justification, as well as action. When everyone was talking, what they were talking about was an improvement process. Mm-hmm. Because what we want to see is gradual or rapid improvement. And so to me, this is an improvement process. And so accountability does actually put one's back against the wall. You must be accountable for your actions. But improvement process says, I work in collaboration with you to get to the target. So I think the language that we're using, as everyone was talking about, is important for us to consider. But the other thing for us to consider is, how do we want people to do this going forward? We want them to work together. And so that's a process of improvement. And we don't always work together, that I do know. So if we want people to work together, we have to frame it in that way.
Okay, thanks. So again, accountability enforcement were 889 terms. That's why we've used them. But I think your message and Jen's message about focusing on how to support performance improvement through learning and through facilitated provision of data are also themes I'll make note of.
Good.
Okay, so why don't we move forward to the next section of our slides. Okay, so I just want to note, so we are transitioning now into talking about accountability options. Ruby just very clearly talked about how the word accountability makes people feel. We use that term because 889 said it's what you need to address. But our language that we use, we can be flexible with. I think the concepts are, there is a concept here that something happens if organizations in the future have performance that is greater than the cost growth target, and we can talk about what those actions should be. But we certainly have some choice over the terminology we use. And I'm hearing that the language is important. So 889, as I said earlier, specifies that if appropriate, there should be a requirement for a provider or payer to undertake a performance improvement plan. That is technically a PIAP, but Felisa, if we want to say PIP, shorten it, I don't think anyone will argue with that. Otherwise, as I said earlier, you're to recommend measures to enforce compliance. Again, that's the literal language in 889. And enforcement in programs administered by OHA and DCBS. So what I want to share first is a proposal for the performance improvement plans, or the PIPs. And so I've got a few slides to do this. So what would trigger a performance improvement plan? Well, as we've talked about, it would be an organization, payer, or provider that had spending that grew faster than the cost growth target with confidence. That refers to the statistical significance testing. And for now, we've got justified and unjustified language here. And so what we're suggesting is that the performance improvement plan would have the following, and as we talked about, it would be developed through a collaborative conversation between the organization and OHA. It would identify the cost growth drivers that are being targeted through the plan using data. There would be clearly identified action steps to address whatever those cost growth drivers are. And certainly they should address anything that was identified during the preceding analysis as being the source of the cost growth, either for one line of business or across lines of business if appropriate. And then there should be a reasonable time frame for completing the work and achieving the outcome. Okay, with an expectation that the organization is going to come back and describe the actions that they've taken to OHA consistent with the performance improvement plan. So obviously the ultimate assessment is looking at future performance against a cost growth target, but there's separately an opportunity to have conversation about whether the actions in the plan were completed and achieved desired results as reported by the payer or provider organization. Next slide. So if an organization didn't produce a performance improvement plan that was acceptable, or if it didn't submit future reports on its completion or progress towards the performance improvement plan, then there would be a fine. And if an organization over time did not make a good faith effort to implement the plan, or didn't complete the plan, which probably would be due to a lack of good faith effort, then there might be what 889 refers to as escalating accountability. So one more, oh no, I've got a few more slides on performance improvement plans, and then we'll pause. So let's go to the next slide. This all, again, is a straw proposal. So OHA would potentially would have the right and would potentially publish information about the plans, who has a plan and why, what they're doing to, what is essentially the essence of the plan, what they're trying to accomplish, and OHA's assessment of whether the plan was successfully completed. That's the evaluation of performance. The next slide has a visual of this, and I think you all can follow this. So there's performance assessed against the cost growth target using the justified language for now. If the target's exceeded for reasons that can't be justified, there's a performance improvement plan. If it's successfully completed, end of story. If it's not implemented or if it's not completed, and as I said on the prior slide, there's no good faith effort to complete it, then there's potentially an additional mechanism. All right. So on the last slide, and then I'm going to stop. Jeremy indicated this earlier, the proposal is that performance improvement plans would not be applied to performance for 2021. So we would be measuring performance in 2021 relative to 2020, but there would be no performance improvement plans. I would say editorially that the mere impact of COVID-19 on 2020 performance, I think, requires this. And then the use of performance improvement plans would begin for 2022 performance. And as Jen noted, it's not until late in 2023, and frankly, maybe even the beginning of 2024, that this would happen. So it's a long ramp up period. So let me pause now and ask for your feedback and or questions about the performance improvement.
So I guess just to reiterate the timeline here. So 2022, there's this sort of accountability starts to phase in, but then because of the 5 years, before you get to that mechanism beyond your PIP, you are at 2027. Let's say you start failing
not quite that long. Okay. So you could have an organization that exceeds the target year after year after year, and if that's the case, you're not waiting for 5 years.
Okay, so that's 3 years, right? Because they have to exceed the target, commit to a PIP, then fail at the PIP.
Yeah, so the proposal, it's actually on the next slide that I didn't get to, is that if an organization exceeds the target statistically significantly and there's no justifiable explanation, then 2 out of 5 years would trigger what comes next. Okay, but I don't want to go to what comes next yet. I want to stay with performance improvement. So let's go back a slide. That's okay. I just want to talk about this process of performance improvement plans. And again, your question was appropriate, Felicia. I just didn't want to go into the next chapter.
Michael, Ken, I was a little taken by the language. OHA reserves the right to publish. Jeremy, I'm kind of curious, why would some folks get outed and some not? That seems like a weird thing to me. It seems to me that it's public information and it should be public. Somebody gets put on a performance improvement plan that's out there, and to have this discretionary thing, it seems a little weird.
Yeah, I mean, I think this, I'll say that there's an overall theme here of we've clearly missed the mark on our language throughout this.
Well,
so with that grace, but I think
just reserves the right.
But I think Ken, it's a really good point, because I think this is one of the pieces that the original 419 task force hit on, which was in Massachusetts, there was a lot of conversations happening behind the scenes that they weren't really sure why somebody had been determined that they were above the target, but that was okay. And certainly other folks around this table who were part of those conversations maybe have a different memory, but I remember people being uncomfortable with that and start saying, we need more transparency. If people are meeting the target, or they're not meeting the target, let's get that out there, and so then we can have a dialogue about why that is. So I think that makes sense.
Important. I think that's important.
Yeah, great.
Can I add one detail to that, to Ken's question? I think one of the things we were considering as staff is trying to be sensitive around what might be contractual specific issues or negotiations that are more confidential or protected, and not wanting to necessarily say, we'll publish all performance improvement plans at all times, because some of the actions that payers or providers might be taking might be addressing some of those things that we would want to protect the information. So I think there's a difference between sort of the list of who's on a PIP versus sort of making everything fully transparent without any sensitivity.
Yeah, it would seem to me that there's sort of existing processes that would, allow for some redaction or whatever, that, there's things you could do there that could still make things transparent and public.
I think that's more what we're alluding
laterally.
Okay, we'll take that back, Ken. Jordan has his hand up, and then Felisa.
Hi, so I've just been kind of soaking in the conversation a little bit, in that this process is actually fairly normal in our industry. We have to live through this all the time with our manufacturers as a dealer. If we miss our marks, they notice the market share change and we get put on a performance improvement plan and we have to justify how we're going to get back on track. So this feels more normal to me, where it seems like there's some discomfort on the call with this group. I would say a couple of the things that make it work better for the manufacturers that we work with that do the best at this is when you have somebody that's part of the enforcement side that is charged with working collaboratively with the group that's on the performance improvement plan, that is to some degree evaluating their success on the ability to help the organization turn around. So somebody working for the manufacturer in our industry would be our assigned manufacturer rep, and their career is to some degree evaluated on their ability to help drive change and help us improve if we're missing our mark. So on the for what it's worth, it might be something that this group wants to consider, to the extent that you have a liaison with the oversight group, in this case OHA, that you have somebody who's directly assigned to that PIP and has some degree of accountability for helping the organization make the adjustments that they need to make. Does that make sense?
Mm-hmm. Yeah, thank you, Jordan. Lisa?
Yeah, I actually was going to say something similar. I really like the PIP. I think because it allows for that change and that transformation. I think performance improvement plans are really critical for individual staff and organizations generally. And I also think OHA has the Transformation Center. And so how does the Transformation Center play a role in the PIP to make sure that they can work with providers? And I don't know if there is an equivalent on the payer market. And so I guess that's a question for Pat or Andrew on if there is an equivalent, how would that work? And could there be an equivalent?
Pat or Andrew, want to respond?
And I'm riding my desk bike. I'm sorry. I committed to do it for 30 minutes a day. So that's the weird
Good
slow.
for you.
Yeah, I'm pondering that. I don't know, Andrew, have you got thoughts on that?
I only caught the second half of the question.
My question was about, so the OHA has the Transformation Center within Medicaid. Hopefully that could be expanded, but they work with most of the providers in our state at varying levels to help them make change. I'm not sure on the payer side if there is something on the equivalent that helps to work with insurers to help reduce their costs. Or could that be created?
That helps work with insurers, or that helps insurers work with providers?
Sorry, helps work with payers. So that doesn't necessarily have to be insurers. It could be any payer around how you're using the tools as a payer to help reduce your costs.
I mean, I would say the Transformation Center is focused on CCOs as well. I mean, and that interplay between CCOs and providers. They've been more focused on quality and less on opportunities to reduce costs. But I think we've always thought about the Transformation Center as having a broader role beyond Medicaid. There's a capacity issue, obviously.
I guess the other thing that occurs to me is that the providers pretty much are the providers, right? Regardless of payer. And so I wonder if you just think of it as a bank shot of the work that Transformation Center and OHA do with the providers, the benefits cascade to other payers, even though there wasn't a direct relationship there, maybe is the right way to think of it. I don't know, that's an interesting question.
Unfortunately, can't add anything else to that either.
Anybody else have any thoughts on this straw model for performance improvement plans?
William has his hand up.
Yeah, I just wanted to reinforce Felicia's comments that she made around the lag in data and the time and the 2 out of the 5 years, that it would be really hard when you find out in 2022 you didn't meet 2021, and 3/4 of that year are already gone in 2022, and so you won't get your results till late 2023. So if there's any way in trying to improve this lag in data for action, I think that's one of the things that's got me a little worried in here, is just the lag time for the information in order to implement plans, you know, and improvement plans to hit your targets.
I would just add, particularly with risk adjustment and a per capita, those are things that don't, or I don't believe, come across in claims data or things. So I have obviously logged my worries about the data transparency is key to collaboration and to change. Timely data transparency.
Well, I think we certainly need to think about a plan for a data strategy that will support provider success.
This is Jessica. I'm not trying to figure out how to raise my hand on here. So I'm going to do it in person, sort of virtually. Yeah, I think that the lag in data could cause some issues here and sort of drag out that process, because even by the time you get your improvement plan, performance improvement plan going, you're potentially 3 years into an issue, and now you're maybe 5 before it actually gets resolved or looks like it's getting resolved. So I think, you know, outside of this group, you know, there should be some effort into maybe delivering more real-time data, at least so you have some incoming data as you're moving along, so you can get a general sense of what's happening before, you know, before you're really having to you know, complete those plans and things like that. I think it just, you know, the quicker you can get it, the better off we're all going to be, so we can expedite the process of bringing that cost down.
Mm-hmm. Okay, all right, that's clearly a theme in our conversation today. So before we go on to the next slide, which is going to be probably an extended conversation, Jack, I know we're 19 minutes short of when we were going to take a break, but I think the next topic might take us for a while. So I wondered if we might want to take the break a little bit earlier rather than starting the new topic. And then,
yeah, no, I think that makes sense. We've been at it now for about an hour and 40 minutes. So I would propose that we take a 15-minute break. Is that good for people? And that, so what time is it now? It's, maybe we come back at 5 to 3, 2:55. We all agree to resume on time at 2:55. Is that okay?
Sounds good.
Okay, we're going to do that. Let's take a little break, and we'll be back in 15. Thank you, Mike. And our folks know that our public comment will now be probably about what do we need now, Michael? Another half hour, 40 minutes to get through the next section?
Well, I think we can stay on schedule, Jack. So I'll present the next few slides. Maybe we'll start conversation and then take a break, do the public comment, and then we'll continue.
Then come back. Perfect. Sounds good. All right, folks, I think it's, are we at 2:55? It seems like we're close.
We are.
All right, we are. So in our desire to get everybody out by 5, because it's a holiday week, let's get started. So Michael, we're back to you.
Okay, thanks. So we are, we should be further by a bunch of slides. I think we want to get up to slide 21. Well, that was too far. Perfect. Okay. So we've talked about performance improvement plans. As a reminder, again, 889 is specific only about performance improvement plans, and then it simply makes reference to other escalating enforcement actions. So now we're talking about what might transpire if an organization on a repeated basis, in this case, 2 out of 5 years, exceeds the cost growth target with statistical significance, and there are no special circumstances that explain why that happened. So I'm going to share, I would say this is less of a finely crafted proposal as the performance improvement plan was than some general concepts that I want to put out in front of you for discussion. They're only generally defined for today, and we're very interested in what reactions you have. So let's go to the next slide, which has a graphic representation. So if there's an organization that exceeded 2 out of 5 years, as we just talked about, or it didn't successfully complete the PIP process due to lack of a good faith effort, or just I think that's probably primarily what it's going to be, for not making progress, then potentially, or there would be some next actions. So I want to describe ideas behind those boxes you see on the right. And this was in the accountability white paper that you received. So the first one would apply to payers, the second one to provider organizations, and probably the third one, contractual actions. That too would be to payers. The term rate review is the first one, and this really applies to actions DCBS takes. And so this could be a number of things. One is performance against the cost growth target could be a consideration during the formal rate review process. There are other options, such as simply giving a higher level of scrutiny in the rate review process to those exceeding the target. DCBS could give a designation of excessive rates to payers that have exceeded the target for unsupported or unjustified reasons. And then there might be some opportunity for OHA and DCBS to do something with the marketplace, and there's no specific proposal right now for that. Rate setting, it might be a little bit of a misnomer. It's two distinct concepts. One is setting a ceiling on provider rates. This is not necessarily saying it's an index to Medicare, X% of Medicare. It could be something that looks at relativity within the state. And so in examples we put in the white paper are 5 times the market 20th percentile, or 75th percentile of market prices. Those are a couple of examples, and it could apply to all of the services of a provider, or just some of them, or just say the large provider that's got a bunch of facilities, maybe just to one facility. It would be setting some potential ceiling, and how that ceiling is defined is open. The other concept here is not so much capping how high rates can be, but rather capping how rates can grow. This would be caps on the increases that insurers can give to provider organizations over time, similar to what PEB and OEB do right now with hospitals, but applied obviously more broadly. So two different topics, capping how high rates can be and capping how high rates can grow. And so that's under this umbrella of rate setting. You'll see it's not really rate setting in a historical fashion of the state setting rates for individual services, but it's providing some limitation on price variation and on price growth.
Michael, before we move on, can you talk about how you see this squaring with value-based payment or alternative payment models that aren't fee-for-service?
Sure. So there's another variation on the theme here. And this is something actually that another state, which we do some work, they apply this methodology. And that is to limit what increases can be in total cost of care arrangements year over year. And so that could be for a global budget arrangement, or it could be for a budget in a shared savings or shared risk arrangement. That those budgets can't grow more than X% year over year. And those growth rates could or could not be, it could or could not correspond to the cost growth target. But the idea is there is a way to apply this concept outside of a fee-for-service rate base. Now, of course, for lots of value-based payment arrangements right now, they still have underneath them a fee-for-service foundation.
Mm-hmm.
So I just want to acknowledge that too.
Michael, this is not unlike what Medicare Advantage does. The federal government gives you a new per capita budget, a capitation rate every year, changes every year. And typically it doesn't go up much. It hasn't.
Right. And so again, this would only be applied potentially on an individual case basis where you had an organization that a couple of times, at least in 5 years, went over the cost growth target or didn't make an adequate effort with its PIP. And so this is not applied uniformly as Medicare does, or CMS does with Medicare Advantage. It would be on an individual case basis. The third category are actions that OHA could take as a purchaser in terms of its contracting with CECOs and with carriers for PEB and OEB. So this could be something as light as a communication between OHA and its contractor, but it could also become a contractual provision that its contractors need to meet the cost growth target, and that if there's non-compliance, there are whatever non-compliance provisions that you might have in a contract. There could be limitations on new enrollment, service area. There could be fines, and ultimately there could be loss of contract as a really large implication. So a menu of choices there. And again, none of these are recommendations. These are really just sort of ideas that were developed to share with you today. And then you can see, of course, we've got an other mechanisms TBD. One idea that we've talked about is to have performance against the cost growth target made a consideration during any merger and acquisition activity. I will note that some of these changes would require statutory modification in order for the state to take these actions, but we wanted to give you a broad array of what could potentially follow a PIP, and so you put these before you today. So we've got about 10 minutes before the public comment. So why don't we start conversation? And if you can all, at least those of you can figure out how to raise your hand, if you can try to do so, because I'm guessing that there are lots of reactions that you all have. And again, I want to invite you to not only share anything that might make you feel uncomfortable, both in word, but also in substance, but also if you have a suggestion for how this should best be done while maintaining a sense of collaboration and a shared common purpose, please convey that.
See Ken's hand up.
Okay, Ken?
So, as I just think about the legislative process, there's a couple of pieces in here that warrant significant vetting on their own. Expansion of the rate review process, moving into regulation of provider contracts, rate setting. Those are big concepts that I have trouble embedding in this without having them vetted on their own. They have significant implications. So I would have trouble getting behind that personally. There may be aspects of it that can be done, but they involve some pretty significant modifications of existing processes.
Yeah, yeah. So Ken, is there anything you would suggest that should follow a PIP if the PIP is not a successful mechanism?
I mean, possibly there's room in existing processes to think about. Like, I'd be curious on Andrew's ideas around, how you could look at this within the existing rate review process, how it could be a factor and be meaningfully applied. I'd be interested in that. On the rate setting side, I don't have any brilliant ideas, but I'd be curious whether Andrew sees a pathway for doing that, say in the existing small group and individual rate review.
Yeah, I just want to clarify. So these options are the backstop. So this is imagining a scenario where there's an organization that says, I don't really care about the public transparency reporting, doesn't bother me, and I'm not going to commit myself to the PIP. So, how do we create integrity for this process if there was an organization that took that position? I think our hope and desire is that there's no one who's going to be like that. But I think we're trying to imagine, well, but what if there is? What do we do?
But to do it, you're going to have to make pretty significant modifications to existing regulatory structure. I think the implications go way beyond what we're talking about.
Yeah, well, they could be so prescribed that they could only be invoked under these circumstances, right? That is an option. Catherine?
Thank you. This may be one of those stupid questions, but if we go to slide 7, and I don't have the SB 889 language immediately available, but I read this. So number 2, or procedures for imposing a performance improvement action plan or other escalating enforcement actions. So I was just curious on the requirement for having an beyond the PIP. Just to be clear.
Yeah, so we put them on the table because I remember when Massachusetts first created their language where there was only a PIP, there was a lot of skepticism about whether that was going to do anything. And while Massachusetts appears to have had some success thus far, I think it's reasonable to be skeptical about whether that's going to play out in every other state that does a cost growth target. And so it seemed to be reasonable to put before you options that would extend beyond the performance improvement plan if, perchance, it wasn't successful.
I would just add on, and Jen, William, others who were on the original task force. I mean, my takeaway was, folks wanted a broader view than just the PIP. They weren't sure. Not saying, I don't think anybody knew what that would be, but I seem to recall folks kind of saying, we're not really sure what the accountability should look like, and that's sort of a later conversation. So I think part of this is just conversation of, not just assuming that it's just the PIP. And that was my recollection. I don't know if others had the same one.
So let me just repeat back. So the or means optional, and the reason to do it may be instructive from Massachusetts, although they've had some success and have some data that might inform us, and a group that got together, 3 years ago? I wasn't here, so I'm not sure that group that formed this wanted more than the PIP in case the PIP was not successful. Am I hearing that right back from Jeremy and Michael?
Yeah, I guess I would, the one modification I put is, the task force a couple years ago, and again, I invite others that were on it if my memory is wrong here. I think we got to the point of recommending this as the program and not a lot of conversation around what does accountability look like. So it was sort of like, that's a future conversation that should be considered down the road when we get to the next level of designing the program, which is where we are today.
So I'm not trying to argue this. I just want to be clear that that group didn't say we had to go to the next accountability escalation. There isn't an enforcement or a requirement because they said that we now, having done this for about a year and understanding the program better, there's not a requirement that we do that in either case.
Catherine, it's William, and that's my recollection. We came to that sort of the penalty phase of it. And I think by that point, everybody on the committee said, well, it's, we've done our work and we'll let another group wrestle with if there is to be any sort of enforcement penalties going forward. But there wasn't a mandate.
That's my recollection as well.
Okay, thanks. I just want to be clear as to what's required and as we talk about what we might do. So thank you all for that.
Thanks, Catherine. Jack, noting the time, maybe we break for public comment now and then Felisa can speak after the public comment.
Okay. Yeah, I think that does. Yeah, I think that's a good idea. We don't want to keep people who are waiting. So can we move to our public comment component? And Sarah, are you going to identify folks for us who would like to make comment, or do we have any written comments?
We do not have any written comment yet. We have 2 folks who have indicated they would like to speak. We have Tom Sensick from Healthcare for All Oregon and Sean Culmer from the Hospital Association.
Okay, so why don't we start with you, Tom? We are familiar with you, sir.
Okay, good. Thank you again for having me and for all the work you're doing. Appreciate the work of the Sustainability Committee. I've been listening this morning. Conversations have been moving along in a very good way. I think early point that was made early on that many citizens are going broke, as well as the business for businesses to do what they need to do to hire and cover people, make sure people are healthy. Another important thing that was said later on was what was missing was quality and overall health. And I think maybe you're aware of that because this is about cost. So I want to just talk a little bit about basically the comment about equity and affordability. I don't know how you're going to get at this group gets at the issue of the cost of dialysis, long-term care, the profiteering, the prescription drugs, the advertising, the Medicare Advantage I see every day on the TV over and over again, all of that, the profits, as well as the issue of pandemics and, in Oregon, house fires. The idea that people are losing their, we'll call it coverage. Well, so you have something really huge to grapple with, and I understand that. But it seems like a lot of these cost things may be out of the control unless the state, and I hope Representative Salinas is still on this, but addresses some of these other issues, like the cost of dialysis, prescription drug limits, because I'm not sure, and maybe you could comment to this, are these items within your scope? But I know one thing that is in the scope, which is administrative waste. And I know that's well within your scope and how to get that number down. And how, unless we address the social determinants of health, how the burden will go to, as you call the carriers and providers in this element. It seems like you have I won't call it an impossible challenge, but in the long term, we're really looking at, in 5 years, as mentioned in this program, the need to transform healthcare, not just to reduce costs. And as you know, and I'll remind you, there's another task force meeting. It's the Task Force on Universal Healthcare, which is addressing these, and I'm hoping you're keeping these in mind, the purposes, values, and principles. One goes back to my first comment, which was made actually in this meeting. The costs, people are going broke, and to eliminate the idea of medical bankruptcy, that when you're looking at cost, you've got to say, will what we do make sure that nobody goes medically bankrupt? That would be a great short-term goal in terms of cost. So it's not just some percentage on a piece of paper that you're all looking at, but you're looking out into the community and saying, is what is being charged across the board? And again, those things that I mentioned, dialysis, long-term care, those kinds of things, are they causing people to still go broke or not? And I think you should make sure that that's one of your drivers in terms of the work you're doing. So thank you very much.
Thank you, Tom. Sean Colmer from the Hospital Association, I believe, is next. And then apparently we have two other folks who would like to speak. So we will get to you as well. Sean, please.
Hey, Jack, thanks for having me. Thanks, everyone. Sean Colmer, Hospital Association. So thanks for the time this afternoon, and I'll be brief with my comments because I think you've heard a lot of really productive conversation, and I think that's the most important you're hearing from everyone here. I think I really want to highlight two things and then sort of end with a comment around focus. The two things I've really picked up, and I really appreciate this, Michael, around your comments around common purpose and collaborative. That's really been the theme of what I've heard today. And I think there really is a common purpose from this group to really figure out together how to really contain healthcare costs in the long term. So I think you're hearing that, and I think a lot of the questions that you've heard today really speak to that. And I think you've heard really clearly as a group, and I really hope that OHA and the team here and the group really continue to talk about collaborative. And then I also want to appreciate the come with ideas. Don't just come to the table and say something and don't have an idea. So our recommendation would be follow the lead of Massachusetts in that way. And if we're talking about collaborative approaches to help contain costs, Massachusetts has done a really good job. We can make assumptions about what a PIP might do or what other things might do, but they've done a pretty good job. And then I want to end with this comment. We can pretend that the healthcare system isn't under extreme strain, that our healthcare workforce isn't under extreme strain at this time, but they are. And so I think the worst thing we could do at the moment is pretend that world doesn't exist right now as we're trying to work on this program. So we really, really ask you to focus on the important pieces of this program and not try to build something and have really complicated conversations. I really appreciated Ken's comments around really complex, really hard conversations are going to have to happen over the next couple of months when our healthcare systems and our healthcare workers are just trying to survive the pandemic. And we can continue these conversations later. But right now, we think the focus should be on that. So OHA has asked us to focus on issues. The governor has asked us to focus on issues. And we're asking this group to focus on that as well. So thank you for your time and your continued work. And we'll keep providing you with feedback as we move forward. Thank you.
Thank you, Sean. Who else is, Sarah, do you have can you identify our other two speakers, please?
We have Mary Beth Corino from Osberg, and we have Kristen Isaacson from SEIU.
Okay. Mary Beth, do you want to make a comment, please?
Yes, thank you. So Charlie Fisher, who typically would attend, couldn't be here, but wanted to thank you for all of your work on this committee and wanted to express Osberg's support for the proposed accountability options set out in the materials for pretty much several different reasons. The proposals cover the main bases, I think, of any accountability system, right? There's a warning system, including input and discussion from potential violators. There are motivating factors to encourage compliance, and potentially, depending on what you all decide based on this conversation, escalating measures for non-compliance. And I think it's really important that we remember that accountability doesn't mean immediate punishment, and these measures do a good job of avoiding that. Payers and providers who haven't met the goal have a level of input to explain why they haven't met it and what they're doing to adjust their strategy to do so. And at the same time, it's not just lip service. If they can't justify, and I know there was some conversation about that, but justify their failure, there's a concrete plan put in place to reach that goal and provide further opportunities for monitoring progress in reducing healthcare costs, which is the main goal that we all want to keep in mind. And that from the discussion and further monitoring comes pressure from the potential escalation of accountability measures. So it's all working together as a system to serve as motivation to adhere to the plan and hit the goals for the next review. And I also just I know that this wasn't part of the discussion today, but the public nature of the hearings and the plans is imperative to that pressure. It doesn't just provide motivation to avoid being called out, it also provides public scrutiny and transparency in the accountability process as well. And then just a last comment in terms of the escalating and the options that are there for rate setting, we would just encourage that you consider whichever option brings down costs the most. But OSPRG is happy to support the adoption of these accountability measures. So thank you all for all your work, and we look forward to the final product.
Thank you very much. And our final speaker, remind me your name, please. I apologize.
No problem. Kirsten Isaacson. I'm the research director at the SEIU Local 49.
Okay. Thank you, Kirsten.
Thanks. I also had the pleasure of serving on that 419 Joint Task Force, and I just wanted to underscore that not only is it my recollection, but also in our report that came out of that task force, we did highlight a performance improvement plan, suggesting that as an option of enforcement, but also calling for kind of escalating options beyond that for repeated violations. And as I recall, the conversation was about like, how do we put more tools in the toolbox for when they're needed? Not that hopefully that they never are or rarely are, but how do we give multiple options for when it's needed? So just wanted to underscore that looking forward to seeing the performance improvement plan as part of this and other enforcement actions, and appreciate the work of this committee making this come to light in a whole nother level. Thank you.
Thank you very much, Kirsten. Do we have any other speakers who would like to make comment? Sarah, or is this concludes that?
I think that's everyone.
Okay. All right. Thank you all very much. And please sign up with us. Stay with us. Michael, let's get back to the dialogue we were having. Where are you, Michael? Are you with us?
I'm here, and I think Felisa raised her hand. So
you did. Thank you.
Her turn.
Felisa.
Thank you. So I just want to, I appreciate the public testimony coming before this. I think the first thing I want to say is that escalating accountability through this process, I actually think is a big issue. One was the cost growth target. Second was transparency. The third is what happens if you don't meet it. And having a long-term vision of that, I actually think is really critical. One of the lessons I think that we have repeatedly discussed in our healthcare community is about not having that for CCOs. And the mistake that we made of not having that escalating plan previous to the implementation of CCOs put us in a position where we were building the plane as we were flying it. And so I think this is another moment to remind us, even though it may be difficult and complex, that it's better to have the foresight and the plan in place than to build the plane as we're flying it. So, and I think it will prevent a lot of challenges and future issues if we can just think a little bit ahead there. So I think taking these next steps is I think really critical for us. The second thing I want to talk about is additional ideas I think were asked to be brought to the table. And so I think I would like to throw in some additional ideas that we could have. I think that we could have Attorney General enforcement, where the AG could do enforcement similarly to that they do around charitable assets, and we could treat our healthcare system like a community asset. And so the Attorney General has a whole host of tools in their toolbox through a regulatory and legal system that they can impose on health systems, providers, insurers when it comes to consumer protection, when it comes to your licensing, when it comes to your private nonprofit status. So that's another place where I think that there could be another round of enforcement done there. The second thing, I think if this is about money, then there could be fines. We could take 10% of your gross patient revenue for not meeting the mark. So you didn't meet the 3.9%, we should take 10% back and do a clawback provision if you were above and beyond that mark of your gross patient revenue on a regular basis until you then meet that mark. So that would encourage you to really meet the mark or come up with solutions to meet the mark. And that could be more on the financial aspect of this. So those are the two additional ideas I would throw out. I would include, I think this is to Ken's point, I think DCBS has a whole set of additional regulations and implementation tools that they can use that they have yet to implement. And so those, we could implement those on broader markets. So your licensing, for example, and other things. So those are some additional options that I'd like to put on the table.
Very thoughtful. Thank you very much. Thank you.
I think I saw Andrew's hand.
Yep.
Yeah, thanks, Jeremy. And I can share some things from a DCBS perspective and touch upon Ken's question around accountability for payers during the rate review process and what could that be and whether there would need to be statutory changes. I mean, that might all depend on exactly what this group thinks accountability should be. But, you know, right now we've got a pretty robust statutory structure around the rate review process. The process itself is rather detailed, has lots of steps to it. But digging into what our review is and what we're required to do boils down to a review of whether a rate, it includes a few things. I think the most important thing for this group is whether the rate is reasonable and not excessive, inadequate, or unfairly discriminatory, and that's set out in statute. And statute then gives us a pretty broad lens in order to evaluate what is a reasonable and not excessive, inadequate, or unfairly discriminatory rate. And two of the things that jump out that are currently in statute that we can look at are historical and projected administrative costs and medical and hospital expenses, including drug expenses, and changes in an insurer's healthcare cost containment and quality improvement efforts. So, you know, especially that second, but those, and there's a number of other things that are already in statute. And in addition to that, we have to consider any public comments raised during the comment period. So anyone in the public could raise issues, or another sister agency could raise cost containment issues. So there is kind of a broad statutory lens through which we could evaluate these things. And it would, I think, more come down to how we collectively think DCBS should look at the rates. Thanks.
Thank you. Thank you, Andrew. I noticed we haven't heard anything much from Kevin. You've been very quiet. And John McConnell, I think you're on. Do you guys have anything you want to add? Not trying to put you on the spot, but trying to be inclusive.
No, listening carefully. Don't have anything substantive to add at this point in time, but think this has been a good conversation.
Thank you, John. Kevin or anybody else that we have not heard from in a while?
Yeah, thank you. I think I wanted to just reconfirm my comments over the last many months about really focusing on the triple aim, quadruple aim. There's a lot of discussion about rate setting, and there's also been a lot of valuable conversations about moving to value-based payments. And we see that this is the future of healthcare. And so my comments are that it may be difficult to try to navigate through both worlds of rate setting and value-based payments all at the same time. I also want to put in a plug for health equity. I'm a strong believer in health equity, and we need to go there as a healthcare community. And as well, we know and recognize there will be more upfront costs of health systems and provider groups to expand into the health equity realm. So those realized costs in the short term, or those increased costs in the short term, we may have we may find it very difficult to show a longer term return on that investment when it comes to health equity measures. It's really important to focus on health equity, but there's no extra money coming in to do that. It's the right thing to do, but health equity interventions take a while to see that return on investment. So you might have higher upfront costs initially, and you're not seeing those realized savings yet on the provider side until several years down the road. So that's my statement, is anything that we want to do is we still have to look at the quality outcomes. What does value-based payments do? And the concern about trying to do value-based payments and rate setting all at the same time.
Thank you, Kevin. I also want to make sure that Ruby or Jordan or Jessica, I know that you guys have been a little quieter than others. Is there anything you all might want to add? Any comments or questions?
Yeah, this is Jordan. I'm just trying to be sensitive to the uniqueness of the industry and really try and let you that are in the industry talk through how this might work best for you. I think that at the end of the day, there does need to be accountability and enforcement, and that has to be taken seriously. But as long as it goes through a improvement process where there is an advocate on the OHA side that's attached to the group that is going through the PIP, then when we get to the other side of that, I think people will find it a reasonable outcome if there is a fine, a fee, a license question that may come into account at the end of the process. And I think that's very normal for most industries where you got to have this kind of collaboration. So I think it's brave for everybody to be talking through this. Nobody likes to figure out how to set penalties on themselves potentially down the road, but I've been impressed.
Thank you, Jordan. And by the way, your insights from the manufacturing process are valuable to all of us, so we appreciate it. Any other comments before we I guess the question is, are we getting to some closure yet on accountability and what we are going to stand for? I'd like to make sure that we...
Jessica and Felicia both have.
Yes, Jessica, please.
So I just wanted to kind of express my support for what Jordan said. I think, this is a really important piece. I would like to make sure that whatever penalties we do put in place or whatever we're considering is enough of a deterrent to really get some active participation in the PIP and make sure that we're doing everything we can so that someone doesn't really get to that point where we're looking at the penalties for not being able to meet those numbers consistently, because I think really that's the goal, right? Is to do this in a collaborative way, in a way that everyone can benefit, and that we ultimately get a better healthcare system that's more affordable. So I like Alicia's addition of potentially a fee there. That's feels pretty normal to me. If you don't hit a compliance marker, you are in violation of a rule. Usually that's kind of like the first thing that happens is you get assessed some sort of penalty. I'm a little bit concerned about the rate setting piece, that it's in direct conflict with the values-based care model. So I think if we're going to look at that, we need to make sure that those two things have the potential to work together, and that's not apparent to me. So yeah, those are my comments. But I think this is a really important conversation. I appreciate how open everyone is being about it.
Yeah, thank you for your thoughts on that, Jessica. Ruby, I understand you and Felicia have hands up. Why don't we start with you, Ruby?
I just wanted to say thank you for everybody being so honest and open. And if you weren't, you will be. But I also see, Ken, I see you laughing. I wanted to touch on the fact that because we're in a pandemic, everyone is drawing back a little bit and saying, well, we shouldn't do it at this time. But we actually are planning beyond the pandemic with our efforts here. And I had some angst, and I shared this with Jeremy earlier because the pandemic had kind of worn me out for a time. And when we decided that we were going to move forward, I had to begin looking forward as opposed to looking at where we are right now. And so recognizing where we are right now, the ability to make those plans, put them in place, does not mean that we cannot change them. And so I do think that penalties are necessary, because if you work in a collaborative function, a process, and you try to get people to do the right thing and they choose not to, the penalty has to be stiff enough to make them move to that new space. And so I believe in the carrot and the stick philosophy. And I do think that most people, most organizations move with the carrot, but there will always be some that will say, I can afford the stick. And so we want to make the stick something that's not affordable. So I just wanted to put that on the table and to say that I think it's critically important that we collaborate and work with people through OHA, because this is new and people will have some difficulty getting there. And so I think all of the things that Jordan talked about, that others spoke about, that have to do with our ability to work with people, to get them to move to that place and to have adequate data, which, by the way, it doesn't matter what industry you're in, adequate data and really good data is hard to come by. And so all of those things need to be in place, and we can't just do it flying by the seat of our pants. We've got to have more current data. When I worked in healthcare, when I was in the state before, the data wasn't current, and it's still not current. So I think it's important for us to think about how we're going to do these things with the data set that we have, and then improving that and moving forward in that way. So it may take us a little bit longer to move forward, but I think we have to do it, not just because of the bill, but because it's time.
Very nice. Thank you, Ruby, very much. Felicia, I understand you have a comment, and then William Olson is after you. So Felicia?
I just wanted to add 2 more additional things based on the comments of my fellow colleagues on the committee. So I think to Kevin's point around the value-based payments and the budgeting, I am also open to setting global budgets for providers instead of a rate, so that you would set a budget that they have to live within, or capping their revenue. I think insurance revenue is already capped under the ACA to some extent, but I would be open to those as well, so that we aren't getting caught up in that rate conversation, that we are getting caught up in the overall and total spend.
Yeah, good comment. William?
Hey, Jack, thanks. And I guess I don't know exactly how we know another organization is thumbing their nose and saying that they're not participating when they may be doing everything they think they should be doing in order to meet the goal. But maybe it's because they've missed the target for so many, 5 out of 5 years in there. I just caution us that when we're working on PIP plans do not take hold in 1 year, 2 years. Perfect examples are the opioid addiction process, issues we have today. Those are 5 years plans to get those costs down. Our behavioral health issues are huge, and you're not going to solve that overnight. In fact, it's even getting worse and adding to our cost. Our elderly population, I can tell you today in our organization, we have 68 patients we cannot get out of the hospital that don't meet medical criteria, but nobody will take them in the community. So I think we just have to understand as well what these penalties could mean to organizations that are really trying to implement plans, but these plans are going to take multi-year.
Okay, that's a great comment. That's very, very true. I want to make sure that everybody has a chance to weigh in here because we're at a point in the agenda where it would be great if we can get some general agreement that what has been laid out here is got the right tools and tone, bearing in mind comments that have been made. If there are folks on the call, on the committee who are very concerned about some of the language and tools that we are discussing, we need to hear that because we do need to move into a dialogue about governance. We have some time. Catherine apparently has a comment.
I'm sorry, I have two more clarifying questions, which seems to be how my mind is thinking today.
Okay.
One, I think Michael said that we were going to circle back on this. Particularly of interest to me on that is because I think Jen and I made the statement early on in the meeting. We haven't really had time to settle this in, having gotten it on Thursday and having to digest it.
Right.
So that was one question I was wondering about the process going forward.
Okay, let's raise that. Jeremy and Michael, could we give committee members a couple of weeks to mull all this over and have dialogue internally with their teams and come back in December to get closure on this? What are your thoughts there?
Well, I mean, certainly we welcome folks to submit comments after today's meeting. I think we would like to at least get some general directions so we can revise what we've put together. I think if we're able to at least get some general direction, if folks have comments that come in later, that would be ideal. But I think we'll have to, need to take a temperature check of the group and see where we're at after folks finish providing comments.
Okay, thanks, Jeremy. And then my second question was around the same due process. We didn't take it forward inch by inch, but I'm assuming when Pat mentioned that there are appeals processes at any point in what we're talking about, such as when OHA would reject a PIP or assess fines or whatever the next, if we go to the next escalation, that there are appeals processes in those decisions as well.
Yeah, I think I took that conversation around appeals as we need to go back and get more specific about what that looks like, especially as part of our overall tweak in languages around the more collaborative process on the front end.
Okay, with that assumption, I'm going to assume that in my thinking through this, that appeals process goes through the whole start and end of the process until you tell me otherwise. Thank you.
So, Jeremy, let me ask you, as the lead staff person, are you getting the kind of consensus that you were hoping for in this part of our work, or are you still muddled about what we stand for related to accountability?
I think we're still pretty muddled. I mean, I think I've heard some very strong concerns around, the expansion of rate. Or budget assessment, budgets, whatever we're going to call that, sort of on the provider side. And I think it might be helpful to understand whether that's, if there's tweaks or there's a place where folks want that in a tape box or not, or we can get a consensus on that. I also heard, I think there's been some dialogue around fines as potentially maybe that's the focus of the escalating next step. And so I think that might be something for folks to maybe have a little bit more dialogue on. And I think we've certainly heard feedback one way or another that no matter what the next step is, it's gotta jive with the effort to move the value-based payment. I think I just feel like there's consensus around that issue of the escalating pieces have to be able to fit together with our efforts around value-based payment.
About that value-based, yeah. So what I'm hearing you say is, could we get a little bit more dialogue around this consideration of imposing rate caps on the provider industry that is not that is sort of ignoring this work has shown a pattern of not, leaning into it, not performing. What are the prevailing views? Maybe I could ask Catherine or Ken or Jen, William, about your thoughts about being subject to potential rate caps, changes in your rates, and mostly in the commercial market, I would suspect.
Jack, I would go back to my comment, and I wouldn't say that I'm out and out opposed to any of those things. I think there's significant modifications in regulatory authority that need to be vetted separately. So, I mean, while I'm not saying, boy, I'm dying to get fined, at least fines are not making huge modifications to current regulatory authority. And those, to me, I would not want to see buried in a bill. I would want to see them vetted separately. If we were to do things around regulation of provider rates or contracts or modifications to the rate review process in some significant way, expanding rate review into large group as an example. I think that needs to be vetted separately.
Yeah. Okay. All right.
Jack, just a quick comment. I heard Alicia mention something about like revenue caps or something to this effect, and I feel like there could be a fee penalty structure that kind of is a little bit kind of fits into that realm where you're not necessarily setting the rate, because there's a whole cost structure, that happens at, when you charge a specific rate, there's all of that, you charge it, and then you have the operational costs and all of those things. And if you kind of look at the actual sort of your net revenue and you look at the percentage and address that in the form of a penalty, that might be a little bit more straightforward, I guess. So in some ways, it kind of has the same impact on the organization, but it's just it's simpler to kind of digest. That would just be a suggestion. I think the rate setting piece is a pretty big piece.
Oh, okay. All right. Jeremy, you have a comment about that, or do you want to react to that, or maybe Andrew, anybody?
I mean, I will say, I don't know how much it's used. I know at least one other state, Vermont, that has a, I think it only applies to hospitals. I don't know if it applies to other providers, has a sort of ability to review budgets, their annual budgets. So at least there's some precedent out there that we've done before. I wonder, as we're just thinking, so I threw out the piece around VBP, which I feel like there's some consensus around that, but maybe we should just test it, that folks feel like no matter what the escalating thing is, it needs to gel with VBP. I think there's been almost no dialogue around, or what I've heard around disagreement around what we've laid out on the PIT process. And I think maybe we should just confirm that folks are comfortable with that. And we've got at least a couple places of consensus, and we can keep moving forward from there. So I guess, just want to ask the question, are we good on what we've outlined in terms of the PIP process, that there's the first year it won't apply in 2021, and then the process for how it will apply there? Any concerns from folks?
Yeah, that's good.
Jeremy,
yeah,
when you say 2022, you're talking about for performance during the 2022 year, right? So
correct.
Seeing the data well into 2023, right?
That's correct, I believe.
Correct.
Yep.
Yep.
So let's do that. I know, Catherine, you have a comment to make in a minute, but can we get is there a general agreement? Can we get some consensus that the PIP methodology and format that's been presented is generally acceptable to people, and we can support it as a committee?
My comment, this is Jen, my comment would be, I want to answer that question, yes, but I'm in my brain, I'm answering yes because I'm assuming that there's going to be enhancements to the documentation around all the things we've discussed, a due process, data sharing, transparency. And so I get a little hesitant to say just a blanket yes, because I have assumptions underlying that.
That's very fair. And Jeremy, you want to confirm that?
Yeah, I think we're trying to get a temperature check. Obviously, we'll bring back something that's revised in December, but I think want to get at least or is there general consensus that with a discussion and some modifications, that part's moving in the right direction?
And
For me, I've always believed that that this would have a PIP, some type of improvement process so that we can drive continuous improvement in action. So I'm supportive of that in any work setting or life setting.
So in order to move this along, because we're now about an hour away from ending this meeting, I would like to hear from folks who generally have any concerns about the dialogue so far around performance improvement plans. Is there anybody on our committee who is opposed to moving forward with modifications that will come back with more clarity in our December meeting for affirmation?
I've got a comment, but it's maybe more of a sidebar and less of a concern.
We'll take it, John. I like sidebars.
All right. So I think there was a comment earlier about what do we learn from the groups that are succeeding, and I was thinking about that, and I think part of my hope, kind of when I look at what drives healthcare spending, we're talking about rates, we're talking about things like that, but I think part of my hope about this work is that it acts as sort of a something that slows down or maybe discourages investments in, say, a proton beam accelerator or something where it's a big investment, big fixed cost investment. Once you get it up and running, then sort of the incentives are there to kind of run people through that type of thing. And so, and that's the type of thing that sort of, that makes healthcare spending go up. It's this sort of investment in these things, these high intensity things. And so, I guess I hope that this work sort of sends a signal that you better think twice before you invest in another ICU tower or proton beam accelerator or something like that. If that's already in place, then PIPs become harder it just becomes harder. If you've already got that thing up and you got a fixed cost and you're paying your mortgage on it, then that's harder. So I think there is something about, what's the message here? I guess I was also thinking about, this, there are some ways for health systems to shift the cost structure that are not so much about rates and utilization per se, but sort of a shift from, if we can get a lot more joint replacements happening in the outpatient side as opposed to the inpatient side, that's probably a good thing. And how that sort of gets sort of talked about or cycled into all of these things, it's sort of, the health system looks different. And so I think this is less about a concern, but more about some of these things signaling to health systems to help them understand, what are the things that we want the health system to look like? Where would you be potentially in trouble? Investing in a new ICU in 2021 might be problematic if you're trying to keep your cost growth low in 2022. Those types of things might be helpful. So
yeah, well, that's the kind of tension that I think this work is going to drive, of which we probably would benefit from. That kind of tension, yeah. Thank you, John. I understand Bill has a comment on PIP, and Catherine, I haven't forgotten about you. I'm coming to you.
Yes, I do, and not a concern at all, but maybe a helpful suggestion when we come back with the additional documentation around this. And just actually throughout these documents, it's pretty clear, here's a provider, here's a payer, and what happens, but it's really unclear when you're both a provider or payer. Similarly, it's unclear in at least some of the conversations around VBPs of, what if you're, 90% value-based payment? So, how does some of these other fee-for-service mechanisms play into that? So just some clarity in recognition that there is a chunk of this marketplace that is, members of integrated delivery systems would be helpful.
Yeah. Yep. So before we get to finish our dialogue about what happens after a PIP, the kind of beyond the PIP, can we try to then get some agreement that the language that we have with a few modifications is generally directionally correct, that we support it, and that we can rely on Jeremy and OHA staff to come back with some of the language that we have surfaced here and try to get final true closure in December. That's what our goal is, I believe. Jeremy, would you add anything?
No, other than I think you said you were going to forget. We're going to forget about Catherine, and I think she's.
Well, I'm coming to Catherine, but I don't know. Oh, Catherine, okay, I'm going to just go to you right now because you may have a comment about PIP instead of beyond the PIP. So you're on.
Yeah. Well, thank you. I do have a comment about beyond the PIP, but I'll just talk about the PIP.
Okay.
I think it's important that we're clear when we say that we'll change or add some enhancements. So what I have captured is the language, that we find a way to have more current and timely data so that improvement cycles can be shortened. I love what Jordan said about the liaison to have OHA investment in the success. And there's documentation changes to due process. I think those were the 4 that I captured. I don't know if there were others. And so next time we would be specific about plus minus on all of those factors.
Yeah, good. Very good. Jeremy, that makes sense to you? Do you have any other factors that we should just identify that we'll come back to?
No, I think those are the main ones. I think there's a whole other slew of input we've gotten around the collaborative nature of the process and the appeals and all of that I think are also captured.
Right. I particularly wanted to put Jordan's in there for conversation.
Yeah, no, I agree. And, I think did have a chance to just touch base with Chris DeMars from the Transformation Center before, and they are doing work with CCOs around cost containment opportunities, things like health-related services, support around value-based payments. So I definitely think there's a way we can leverage the Transformation Center in this as well. I guess I would throw out, Jack, I think if there's general consensus, recognizing that we've got to come back and take a look at revised stuff around the PIP. There's general consensus around anything that goes beyond that really needs to jive with value-based payment. Maybe that's and I think we've heard a lot of concerns from folks on and some other ideas out there. I think maybe we stop there for the day and we could come back with a revised description of our process, the revised PIP proposal, and then I think we can come back with another discussion that talks about some of the other options we laid out today, some of the concerns. We'll take some of this feedback back. I think if we get any other ideas, and then I think land on the, what goes beyond a PIP at the December conversation. And I think if we could get feedback from folks between now and December 4th, that should give us plenty of time to be able to consider that incorporated into the December conversation. Does that make sense to folks?
That makes sense to me. I'm seeing some heads nodding. I would add one thing, Jeremy, not to spoil the apple cart here, but I do think that, and I hope this isn't the case, but it is possible that no payer will hit the target in the first year or two, because for whatever reason, utilization spikes for everybody, whatever it is. So I do think that your staff should be thinking about what would the reaction be from the committee, or I should say from the OHA, if for whatever reason there was general failure by all payers and providers to hit it. We don't have to answer that now, but it occurred to me that is a possibility.
It has been on our mind, especially on the other end of a pandemic, and I think also as part of the reason why we've been saying we hope there's tools we don't actually have to use, but it is pretty important that folks take this seriously and that out of the gate it doesn't immediately get dismissed as, well, we tried that and it's not working, so now we've got to go to something completely different.
Okay, let's move on now. Do we have further dialogue that needs to take place now for actions beyond the PIP? Or do we want to come back and address that in more detail at our December meeting? Jeremy, do you have some thoughts on that in terms of what you feel you need to close out our work here?
think we're good unless there's any final comments that folks have that they feel like they haven't had a chance to say yet.
Okay. Yeah, good.
You know, the one thing, Jeremy, that I may have said to you the other day, that we've got some sort of soft language around, like some of this stuff wouldn't kick in immediately. It might be good if that we had a more specific timetable that said that the stuff beyond the PIP wouldn't happen until 3 years out or whatever the time frame is, so that people aren't expecting it. That's, you know, there's just an understanding that we're first putting the effort in driving the change, and maybe that's built into things already.
Thanks, Ken. I definitely took a note. A couple of folks made comments around getting clear on the timeline and what the next couple of years look like. So we'll definitely work on that.
Okay, so when we come back to the end of the agenda for next steps, Jeremy, you and or Sarah will summarize for us what we will be bringing back to get closure on the PIP and beyond PIP. So we're clear on that for December, okay? So let's talk now. I believe we're now into the part of the agenda where we're going to discuss governance and how we expect to govern this work over the coming years. So with that, Michael, are you going to lead us through a set of slides on this, please?
No, this one's for Sarah, I believe.
Sarah, I meant, thank you. I knew that. Sarah, my favorite person in the world. Speak.
Thanks, Jack. Jeremy, do you want to kick this off and then hand to me, or do you want me to just start?
Sure, I can kick it off. Senate Bill 889 creates this program within OHA in collaboration with DCBS and with oversight from the Oregon Health Policy Board. We've been talking throughout last year about a number of things that I guess I would put in the governance bucket around sort of who's doing the public reporting, who's doing the public hearing, and we've talked about various technical advisory groups, as well as the potential for ongoing stakeholder groups. And so what Sarah's really going to try to summarize is bringing those things together. And one thing that I will just say at the front end is that our charter for our group, our charter that we approved ourselves, or you all approved yourselves, put an end date of this group at the end of the year. The bill actually doesn't sunset this committee for another year. And I think one thing we would like to talk with you all about today, in the vein of the gift that keeps on giving, is I think there's been a lot of comments today around the importance of standing this up and making sure it really gets stood up correctly and continues momentum. And so there's going to be a lot more technical work that happens next year. And one of the things we'd like to be able to talk with you about today is whether it makes sense or whether folks would be willing to stick around, maybe not for nearly as intensive of a year as we've had, but be able to stick around as we're getting to the next level of implementation. And you all are so invested in this and are so well versed in it, and it would be, I think, a loss for us to sort of start over with a whole new group. So with that, Sarah, why don't I kick it back to you?
Thanks. So given that we've uncovered that line in Senate Bill 889 and realized that we have a whole other year before you all officially sunset, we split our proposal for you today about governance into 2 phases. So we have an interim phase that is 2021 and really relates to work that we'd be asking you as the implementation committee to continue and what that scope would be. And then we have the future state, so 2022 and beyond. Next 2 slides, Michelle. I'm going to talk about the interim governance first. So as Jeremy just said, we'd like to ask you to continue meeting through 2021. There's a lot to potentially adjust in that meeting. Next slide. Which would include updating the charter, one, so that it doesn't sunset, and updating the charter to reflect any revised charge. The initial charge of this group was really to deliver and develop these recommendations, but there's so much more work that we've identified and conversations that we know we want to continue as we go through the initial launch of the program. So we'd like to spell out what some of those things might be in the charter. We do want to take this as an opportunity to potentially update the membership. We know that some of you may not want or be able to continue, and we've also had some suggestions over the last year about missing voices and who else we might need to invite into the conversation. I think there's a balance there. This group certainly has gelled, and we really appreciate all of the engagement and expertise that you've developed over the year. So how do we supplement that without completely replacing? How do we balance that out depending on your availability to continue? And then, as Jeremy said, the meeting frequency, we don't think this is necessarily a monthly implementation committee anymore in 21. This is likely every other month or potentially quarterly to help with some other key decisions or oversight. Next. So in terms of what we think that work in 2021 might look like for you, sort of broadly overseeing the program launch and initial implementation, that would include any iteration with the technical group about the data submission specifications, continuing to finalize things like PIP requirements or other accountability mechanisms. If there are any changes, if we identify any immediate missteps where we got something wrong in the initial recommendations, we'd like to bring that back to you for consideration. As we've mentioned multiple times in all topics, we want to continue to develop and implement the data use strategy. So staff already has some initial reports that we're working on that we've lined up to release next year. There'll be the baseline data that we'll be collecting and releasing next year as well. But we know there's a lot more that we can dig into. And I think once the recommendations are sort of fully hammered out after December, there'll be more time to come back to talk about some of those potential analyses and what would really be helpful. There's continuing to look at those reports as they're coming out and reviewing and understanding what the cost growth trend is, what some of those key drivers are. I think too, the conversation we just had and the importance of more timely data, thinking about where we can invite others to share data, or you can share what's happening within your own organizations to supplement that, so we really get a better understanding of what's happening. Last month, we had proposed, and you had accepted the proposal to work with the Health Plan Quality Metrics Committee and the Health Equity Committees to finalize the plans for quality and equity measurement. That is all work that we'd see continuing in 21 that you would continue to be involved in. And then there are potentially some conversations that we keep coming back to or saying we need to keep touching base on them, and that would include what supports do payers and providers need to meet the target, and what are some additional opportunities for lowering cost. Next. So for 2021, we would propose keeping this committee moving forward to address all of those things that I just described, providing those recommendations or that input back to OHA and DCBS to guide the launch of the program, and then providing regular updates to the policy board and the legislature as they continue to be interested in this work. I don't think we're anticipating something as formal as a second recommendations report. I think this would be more iterative, addressing things as they come up and continuing to guide the agencies. And as I mentioned earlier, we want to stand up the technical advisory group, and that would be informing OHA on the data submission template and specifications, the data validation processes, et cetera. This is a model that we have a lot of examples to draw on from some of OHA and DCBS's other work, where we have a committee and a technical group and they work in an iterative fashion. So some of you might be interested in participating in that technical group. Some of you might want to nominate other more data focused staff from your organizations to participate. We would definitely reach out to some of the other payers that are not represented currently on the committee to make sure that their technical folks could be involved as well. Next. Right, so TAG would also not be a decision-making body. I'm not asking them for anything specific, but more just the feedback and the iteration as we work through those details. And
Sarah, a question on that.
Yep.
Will providers also be invited to participate so that there's feedback on and understanding that starts to develop on what the data is and how we might be accessing and looking at it as well?
Yeah, definitely. I think our first line would be to make sure all the payers who will be the ones submitting the data are on board, but that provider perspective is really important, and we'll want to make sure that we invite providers. I think that's a great place for some suggestions. I think it's a little, we've certainly heard about the need for more provider representation, especially from independent providers, not necessarily just the systems. And so thinking about the right balance and mix to provide that perspective on the technical group as well as on the future iterations of the committee.
Thank you.
And then I think just to flag, the model that OHA uses for our technical groups to date, these are open meetings. It's not necessarily a formally appointed membership. It's here's a tag meeting, here's our agenda. If this is relevant, you're invited to participate. And certainly we do outreach to make sure we have people participating, but it wouldn't be limited to you can't have a seat at the table. So just graphically how we see this working, since we like to complicate things, we've got multiple committees and agencies and it all interacts. So in 21, we would see the work of you all continuing in coordination with the Health Plan Quality Metrics Committee and Health Equity Committee to develop that quality and equity plan. We'd have the technical group working. There's been all of the conversations around VBP implementation, and that is developing. And so that's sort of related work that would continue to iterate here. And all of this would be providing updates and direction back to the policy board and to the agencies. All right, I'm gonna stop there, go back one, Michelle, please. Any questions or comments about about 2021 before we talk about beyond that?
Can I assume that since we're not hearing from anybody, that there's general agreement that the group that we have in front of us here could be available next year, maybe with a few, you don't have to commit right here and now, but it sounds to me like there is, silence tells me that there is desire to keep the group going. Maybe we can even meet in person one day and get a cup of coffee and a bagel. Imagine that. What is that generally the sense that we should be left with, folks?
Well, Jack, I expect I'll be around.
Okay, good to know. Who said that? Was that Jeremy or Pat?
It was Pat.
It was Pat.
Yeah,
Pat. Okay, good. Well,
Pat gets to decide whether I'm around or not. So.
Oh yeah, I guess Pat decides whether you're around, Jeremy. Good to know, Pat, because yeah, your job is not going away anytime soon. All right, then hearing nothing, then I think, Sarah, what I'm sensing is that there is a desire to keep the group intact, generally speaking. If people have different thoughts about it for commitment, you can reach out to me, you can reach out to Jeremy, and we can discuss that, okay?
And I know that it's hard to commit to something without a lot of details. So yeah. One of the things on my list to come back for in December is a slightly more concrete work plan for what 21 might look like, meeting frequency and some of the key topics, so you can get a better sense of what the ask actually is.
That's perfect. That's great, Sarah. Then maybe we can make some decisions then. Yeah, great. Thank you.
All right, let's talk about after 2021. Ahead 2 slides, please. So we have heard, we've had a lot of feedback about this. We've had a lot of discussion internally, and we've had some regular updates with the policy board about this. And we originally thought we were going to be proposing the new structure immediately for 2021. And so some of that pressure has been lifted with continuing the current committee. And so that gives us time in 2021 to develop the new governance structure. That means time to be really thoughtful about the charters, time to be really thoughtful about recruitment and making sure we have the right representation, and time to launch. So I see all of this as a very preliminary proposal that we would spend time continuing to develop over the next year, which would include that very deliberate recruitment before the current implementation committee sunsets at the end of the year, and we stand up the new governance structure for 2022 and beyond.
So Sarah, what you're saying is the implementation committee, as we know it today, would have a voice in helping define what future governance should look like. Is that what I'm hearing?
Yeah, I think both now, some feedback on my next couple of slides, and continuing to iterate over the next, 6 months.
Right.
Next slide. So as we were thinking about what we need for governance, we organized our thoughts around a couple of key questions. One is, what should the future governance body be responsible for? How should they best be structured to address those responsibilities? And then what representation is needed? So I'm going to go through proposals for each of these. Next is the proposed responsibilities. So some of these might be exactly what you expect. That oversight role for ongoing program implementation, so understanding details or where changes might need to be made. Way back in February and March, when we set the cost growth target, we recommended that a future committee revisit the cost growth target value for 2026 to 2030 and determine whether or not it should drop to 3% or if it needs to be adjusted. That would be a responsibility of the future governance group. Continuing to review and understand the cost growth trends, monitoring for unintended consequences, exploring opportunities to improve equity, understanding progress towards VBP goals, identifying and addressing opportunities to reduce cost growth as revealed by the data use strategy. So again, the way we envision the program is we will be producing the reports and the performance on the cycles that we've discussed. All of that information would be brought to the future governance groups for opportunities to review, understand, provide additional direction. Maybe some of that is suggesting additional analyses or deep dives. Maybe that is suggesting who might, or key topic areas that might be appropriate for focusing the public hearing on. When we look to Massachusetts, for example, their public hearings have shifted every year. They have a public hearing every year, but the content and the topics that they focus on are a little different. So this governance group would focus on what are some of the sort of the hot topics of the day or the year that should be brought to that public hearing, and who might it be really important to hear from.
Sarah, I think I'm hearing that Felicia has a hand up. She may have a comment.
Go ahead, Felicia.
Please.
I do. I just have a question on the process and setting up this and how the Health Policy Board is part of this decision making in this ongoing committee, because I think they're statutorily in charge of the healthcare in our state technically. So that's my question. How are they involved in sort of where most committees are created at their behest, or even the statutory committees fit within them? So
yeah, I think that is something we're still thinking about. Jeremy, please correct me here. I think we're thinking about what is the right scope for the policy board, and should this proposed future committee sit under the policy board? Obviously, the policy board is very focused on cost containment as one of their key priority areas. It's part of their strategic plan. They would certainly be informed by this work. As I'm going to propose in a couple more slides, we do really explicitly want to say that we think it's the policy board's role to convene the public hearing, and that's separate from this governance group, from this future committee group. So this gets into sort of membership and representation, and sort of how we need industry representation, healthcare system folks to really be digging in and understanding what's happening and informing that. But who is the policy board at that higher level and a little bit more of an arm's length removed from the system and the industry to be convening that hearing? So I think we definitely see an interaction between the committee and the board. Whether or not this is formally a committee of the board, I think is still open, unless Jeremy, you have an update that I don't.
No, and I think the board is excited to really take on this work leading up to the first public hearing, and getting their arms around getting more comfortable around conversations around cost. I think the important part of having the board be sort of the sponsor of the public hearing is that I think these public hearings, they're kind of grounded in cost, but I don't think that's the only topic. I mean, I think this is I see us getting to the point where this is really a couple-day conversation around the state of the healthcare system in a given year, and we're going to clearly want to pull in quality and equity and broader sets of challenges. And there's all sorts of things that the policy board is working on. And so I think it's a way to kind of each year build towards an event that really is, okay, what happened over the last year and where we're really trying to focus in the next year. But recognize that there will be a ton of value for us as an agency, and I think as an advisory group into the board, to have a group of stakeholders who are much more in the weeds of the day-to-day challenges that they're seeing, and can understand data and can help us inform. Look, we can't dive into every single issue every single year. We need to figure out what the top kind of things are that we really want to focus on.
Carry on.
All right, let me go to the next slide and share what we're thinking. So when we thought about that list of proposed responsibilities and who the people were that we would need to appropriately address those, we really came to the conclusion that we think we need 2 committees instead of 1, and that these committees would be parallel and equal and sort of work together, inform each other's work, but not a hierarchical committee and subcommittee structure. And I'll get to why in a second. So first committee would be the Implementation Committee 2.0. So the future iteration of this group. The industry representation, technical expertise, really good familiarity with the trends, what's happening, some of the mechanics of how the program has been designed, more of the programmatic focus. The second group is the group that we would like to focus on cost, equity, and unintended consequences. And if you jump to the next slide, you can see how we're thinking the responsibilities are shared. So Implementation Committee, ongoing program implementation, revisiting the cost growth value, looking at VBP goals, and reviewing and understanding the impacts on quality and equity. The Cost, Equity, and Unintended Consequences Committee is where we want to have some of those conversations about the impact on consumers. And again, understanding the cost growth trends and key cost drivers, but with that specific eye toward consumer representation. And we really struggled with this proposal. I think, certainly looking forward to your feedback on this, but I think there's the tension of sort of one, who is a consumer, and are we talking about an actual member? Because in some ways, if this is a cost growth target program that applies to all payers and providers in the state, we are all consumers. And so this isn't quite as specific as must be a Medicaid member. And so then are we talking about consumer advocacy groups? And if that's a layer of disconnect that we don't want. And then we looked at some previous experience that we've had with other committees of the board and other work where it's mostly an industry or mostly a technical group with one token consumer representative, and whether or not that's setting them up for success to be able to have a conversation and influence any of the work. And so we thought that it would be a more robust proposal to separate that out and have two parallel committees rather than a subcommittee, which introduces power dynamics that we also wanted to avoid, but with a different charge and a different focus. Although, again, both committees would be charged with understanding what's happening and identifying and addressing opportunities for cost growth and equity. And both committees would be asked to provide recommendations or inform the policy board in terms of what the public hearing topic should be focused on. So playing this out, for example, it could be really, it could play out where the Implementation Committee 2.0 really, really focuses on something that's impacting the industry. Change in a very specific service. Say a new benefit was mandated and that really changed prices, or a new high cost drug was released and that changed costs. That would be the industry focus. A consumer focus might have a very different sense of how that was playing out, and we would also want that to be taken into account. So they're both valid perspectives, and we didn't want one to be given dominance over the other. So next slide, I think we had a couple of internal conversations with the Office of Equity and Inclusion and the Health Equity Committee about how this might fit with their work, because we didn't want to essentially say, we already have a Health Equity Committee of the Policy Board, why would you create a second equity committee? Is that not duplicative? And we thought that this would be really focused on the cost equity issues and the cost to consumers and the unintended consequences that you all have been identifying throughout the past year. We really wanted these groups to inform each other and not set one up to rubber stamp the other's work. And we did have some conversation about if we just assigned this body of work to the existing Health Equity Committee, would they be able to take it on and have the sort of the depth of conversation to dig into these weeds and not just be asked to approve a proposal. All right. I'm going to stop there because I think we have questions.
Felicia, I guess you want to add a comment here, yeah?
I have some concerns about this. If you could go back to slide 43. So when you look at this, if you divide this between the industry committee and a consumer-based committee is sort of the description to break it down on the implementation committee and the cost. So the on slide 43, sorry. Oh, it's just going now. Is like oversee the ongoing program, revisit the cost growth target for 2026 to 2030. I believe that any adjustment or changes to the cost growth target should be both a consumer and an industry conversation. And that should not be a division of labor between the two groups. I also think the review and understand the progress towards the value-based benefit. There's the technical implementation of value-based benefits. The review and the progress toward is a consumer-based concern as well as an industry concern. And understanding the impacts on quality and equity, I think falls into that same category. So when I look at the breakdown of these two committees, one, I think if you're a consumer advocacy group or organization or even an individual like Tom or other folks who've attended all of these meetings, monitoring two committees that are supposed to do roughly the same work, to me, I think is, I think that's too high of an expectation. Two, I think by dividing it out, you lose that voice. I think one of the benefits of this committee is I want to believe that some of the consumer perspective has moved the industry and the industry perspective has moved the consumer. And having separated, I think you lose a lot of that. And even in parts of the conversation where, you know, am I in the technical weeds of how an insurer is going to submit their data to the health OHA? No, that's okay. And it's an hour to 2 hours of the overall committee time, and I can sit there through it. So I feel like I have some super big concerns about this division.
Yeah, I think you make some great comments, by the way, Felicia. Thank you very much.
Yeah, and I'll just say we've been arguing back and forth internally on the different pros and cons of this, and the whole two committee concept really came out of, should we have a group that's really focused on unintended consequences and feels really safe being able to talk about those, and then we've had the same debate of, yeah, but don't you want everybody to hear that conversation? So I think, you know, I really welcome the direction here.
Let's have some other comments on this this not even a proposal, it's just a early concept, let's call it that.
Yeah, let me clarify. We're not looking for a decision today on this. I think, again, similar to the conversation we just had, we are throwing some ideas out. We're looking for your feedback and direction. We can come back with something more solid that would be included in the recommendations at the December meeting.
Yeah, very good. Other comments? Catherine has her hand up. Catherine?
I think we're better when we have consumers in our dialogue. So I would favor trying to pull these together, although it makes for a big workload.
Okay, thank you.
I agree. I think that when you start pulling this apart more, you lose the benefit of the multiple perspectives that I think is really important for big systems. I also think, you know, having two equity committees is like really wonky, and I think while it may not be too confusing to the people who are on the individual ones, it's going to confuse everyone else about where they should go for information. I mean, I think that the collective team could get through the content and get through the work. And you might be a little bit more manageable than you think, because you're not repeating some of the same information in different committees. Because what happens is, you know, the cost and equity committee still has to know what's happening on the implementation committee, and you can't completely disconnect those two things.
Yeah.
So you're going to be repeating that information however many times it takes for all of these different committees to really get it. So I don't know. I think you'd be better off just tackling it together as one.
Yeah, Jessica, I love the term really wonky. That's awesome.
Yeah, we like to do that in Oregon. It's all right.
Very apt. I understand that William has a comment.
Yeah, and it's no different from what you've been hearing, Jack. I mean, I would support the single committee. I think you're going to get conflicting answers to the same questions if you have two committees. And so I really just support what everyone else has been saying.
Okay, I think there's a theme emerging here. So I personally would agree with that for what it's worth. If someone asked me to describe the difference between these two committees, I would struggle with that, I got to admit. So,
can I ask?
Yeah, other comments?
Yeah, it's Kevin here with his hand up.
Kevin, yeah.
Yeah, so I'm in agreement with having one committee. I wonder about if there would be enough work actually for a whole other committee looking over a 5-year period at unintended consequences. But we might be able to suggest that we have a subcommittee that would form ad hoc if we needed them to report back to the larger implementation committee to specifically look at unintended consequences.
Yeah, good. Very good. There's a man who knows his committee work. Thank you, Kevin.
It wasn't really, Jack, it really wasn't intentional, but now I'm starting to think that I wish it were, that we end the meeting after, maybe what would be a divisive issue to throw out a stupid idea for everybody to unite around killing. So we'll try to come up with another one for the next meeting.
That would have been the unintended consequence, I guess, huh, Jeremy?
Can I ask committee members another question? I think one of the comments that we've heard and something that came up in our internal debate about this is already one of the larger committees that OHA has. We have 18 members, and we've also had a number of conversations already about who's missing and the need to add additional representation. So, I mean, I think clearly we're in a virtual environment right now. Someday we'll meet again in person. We can always support more people technically, but in terms of having a large group and sort of unwieldiness, do any of you have any concerns or reflections on that?
Excellent question. Thoughts, anybody?
I believe this is a large and unwieldy group and you guys are killing it, so.
Well, that's kind of you to say that, Felicia. Thank you for your help along the way. I guess one of my comments or questions is, we have a number of people on this committee today that are real stakeholders in these decisions. And decisions that the committee makes in the future will have real consequences for the organizations that they represent. And that's true today, but it will be very true once we get into the work. So I guess one of the questions is, can the committee be composed of people that are actively running organizations that are impacted by these decisions? I just throw that out as something to consider.
Can we go ahead 2 slides? I think, let me cover one more thing that might, sorry, one more slide and one more. I can't count. Okay, so we thought this might be helpful in teasing this out in terms of who had what responsibility. And let me just run through a couple of these and then come back to your industry question, Jack, because I think it's really key. So when we were thinking about who would be responsible for what, so adjusting the cost growth target would be the future committee in 2024-25. And now when I'm going to say future committee, we're single combined committee. Who is deciding about the PIPs and who needs to be on PIPs and that accountability determination we just had. Earlier in the meeting, we proposed that that's an OHA responsibility and that's the agency organization one-on-one conversations. Selecting who should testify at the public hearing and who should be heard from or what topics we should focus on is something that we would charge the policy board with. Certainly we'd ask the future implementation committee to give input onto that and to guide that direction, but we would put that up to the policy board so they have some of that distance from the impact. Recommending the quality measures would be the implementation committee plus the health plan quality metrics committee, and then identifying opportunities and additional direction. We think that's really a shared responsibility. So regardless of the committee structure, some of that is for the committee, some of that is for the policy board, some of that is for the individual stakeholders.
Yeah, excellent. That's very helpful. Thank you, Sarah. All right, let's keep this conversation going. I mean, we do have general, I think, agreement that splitting this work into 2 committees is probably not the most sensible idea we've heard. I'm being kind. What other comments that people might have?
Jack, just to respond to what the comment you just made, sort of the flip side of Catherine's comment, I think there's advantage to have stakeholders in that discussion with consumers. So I think you bring them together. In fact, I think one of the biggest challenges, which is a good challenge, is it'll force industry folks to speak in plain language and actually talk in understandable language about what it is that we do, which we're real good at obfuscating.
What a concept. Is that even possible? I guess we'll find out, Ken. Thank you. Other comments?
I do hear about the number of people on a committee can make it challenging, but I think I think you can still keep your committee pretty concise if you pick the right people, and they will participate. What I've seen in the past is, you have every, let's say every agency head and every, support person and every nonprofit, executive director joining a board. And then it's really challenging to even just communicate the right amount of information to those folks. And you just don't get the level of participation that, that you need in order to make good decisions. And so I think who you have on there makes a big difference, and also keeping that number to a reasonable number. Definitely like under 40 people. You don't want to get too big of a where you can't put everybody in the same room and give people a chance to really communicate with each other.
There are cities in this state with under 40 people, Jessica. So yeah, that's a good. Okay, let's, other comments. Other thoughts here? Sarah, do we want to get closure on this today, or you want to come back with some firmer recommendations based on this dialogue in our December meeting?
Well, let me see if we need to. I definitely heard clear consensus that single committee, not split, but I didn't hear any concerns about the proposed responsibilities. Is there anything that you feel like you need more information on in December? Or do you feel like a single committee with those responsibilities, you're good recommending that for the future?
I think Ruby has her hand up. Ruby, you want to?
Yeah, I did have my hand up. Thank you, Sarah, for running through that. The one comment that I wanted to make on size of committee and the makeup of committee has a lot to do with agenda setting. And I believe that, to your credit, Michael's credit, Jeremy, Sarah, Shell, everyone who's been involved in the agenda setting, and you as well, Jack, and keeping us focused has a lot to do with whether or not we can get through the material and actually make decisions. I don't think that every person that joins a committee has to speak for 10 minutes. I've learned as I get older, I probably don't need to. I used to think I did before my hair started turning gray. I do believe that it's important to have your consumers in the same room with industry, and to be able to say, from an industry perspective, how that's going to impact them, and from a consumer perspective, how it's going to impact them. We are all consumers. We realize that when we go home at night. But sometimes if we have on our work hat, we actually forget that we're consumers and vice versa. So I just think it's important to keep people in the same room and to keep the dialogue going, especially when you're trying to make big changes.
Very good. Thank you for that. Back to Sarah's question. Sarah, I like the way you've laid this out in terms of responsibility. Do people have comments about that? And are you comfortable with the way this is generally?
Michelle, can you go back to the proposed responsibilities slide, please? One more.
Yeah. There we go. Yep.
The one addition that I would have,
Yeah, please, Felicia.
I think the one addition that I have that was is just continuous data improvement, which maybe is under here. No, it's the data use strategy, but just general improvement on time. I think timeliness was the roundabout question we were talking about earlier today.
Okay.
Okay.
So how about we do the same thing? If you have any additional comments or thoughts about future committee structure, both the interim work and the 22 work and beyond, any additions to proposed responsibilities or other thoughts, if you could share those via email by December 4th, we can just clean this up and have a final document to approve in December.
Very good. Okay. Other final comments before we move to our kind of next steps and what we can look forward to at our December meeting? Hearing nothing. Okay. Very good. This was a good dialogue. Okay, so what are the next steps, staff?
It
Who's
sounds
gonna-
like we got a lot of redrafting to do, Jack, or I should say editing.
Editing, yeah.
A lot of editing to do based on the feedback that we heard in response to both the first half of the meeting and the latter portion.
And Michael, just to clarify, do you expect to get more editorial comments back over the next week or so that when you prepare the next deck, we've got everybody's thoughts there?
We'll follow up with an email out to everybody. But yeah, I think our ask is folks send in additional comments on any today, as well as the escalated pieces by the 4th, and that way we can incorporate things in.
So that we can close out with more specificity our accountability model and methodology.
On the 16th, yeah.
Yes, correct. Very good. Okay, that's a good one. What other topics, Sarah and Jeremy, are we looking at for December?
We really only have one other topic beyond the accountability and governance and landing that, and that's looking at the full set of recommendations and the report that we will be submitting to the policy board and the legislature in January. So our process all year has been to update the recommendations after each meeting in that decisions document. So all of that. And then we'll update the interim progress report that we submitted in September to reflect the committee conversations since then. And we'll be asking you to just take a look and sort of final packaging of everything before we present it to the policy board in January.
Great. And is it fair to assume, Sarah, that will get out to the group well in advance of the meeting?
How would we like to define well in advance?
Well,
I think the Thursday before is too late. I can aim for a week in advance.
I think a week in advance is reasonable. Yes. Yeah, I think a week in advance would be great. Yep. All right. What other items do we have, folks, for the good of the good here? Is there anything else that anybody has on their minds? I'd like to just close by saying how grateful I am for everybody's time and commitment to the work and for the dialogue. I thought the points that were made today were excellent and very thoughtful and very useful. So thank you for that. Are there other comments that anybody would like to make other than wishing everyone a very healthy and happy Thanksgiving and a safe week?
I just want to echo your comments, Jack. Really appreciate everybody's patience. I know folks had a lot of thoughts coming into this, and really appreciate all the feedback and sticking with us to work through it. We're really grateful for everybody's commitment to this.
Yeah, I really believe that it's very difficult for stakeholders who will be so impacted by this work to be so forthright. And I want to compliment particularly folks who are on the payer and provider side. All of our folks have done a great job, but you will be impacted by this. And I want to congratulate you on putting the interest of the state in front of everything. So thank you for that. That's not easy.
Hey, Jack, it's Kevin here.
Yeah.
So I just wanted to wish everybody a really safe Thanksgiving. And I'm not sure if you're aware, but the Hospital Association, in conjunction with the Oregon Nurses Association and the Oregon Medical Association, took the governor's recommendations just a step further to try to have a very safe Thanksgiving. Don't cancel Thanksgiving, but just have it within your own home. We want Oregonians to be safe. We've seen increased COVID cases over the last 4 days. We really have to all do our part. So please, if you are celebrating in your own home, having any others outside of your bubble in your home, try to maybe celebrate outside where there's good ventilation and airflow. Make sure that you're keeping a mask on, even with others that are outside of your bubble, and keep that social distancing. So my wish to you is to have a very happy Thanksgiving. I want to see all of you after Thanksgiving and after the December holidays. So please be safe.
Thank you, Kevin. Well, with that, I will just once again thank all the staff for the great work. To Michael and Megan, thank you for making this so much easier on us with all of your insights and and preparation. And just want to wish everybody a very happy and healthy Thanksgiving. And we will see you on December 16th.
Thank you, Jack. To you as
Thanks,
well.
Jack.
Thanks, folks.
Thank you.
Thank you. Thank you.
Cheers, everyone.